We are live now, ma'am.
Yes. Good evening to all. Okay. I welcome you all for the TNFOG Marathon CME, which is conducted every month, second Friday. Why it is called a Marathon CME means we have 3 sessions. One UA session, one update, and third is panel. We will have one theme for every CME. Today's theme is multiple pregnancy. So we have 2 UA speakers, and the speech they will be judged by the 2 senior persons, and who is the best orator will be awarded a plug in the annual conference. And after each session, one questions of UA and update session and the panel session, one question will be asked to the delegates that will be posted in the screen. Whoever is answering first, that is fast, they will be awarded a small gift. This is mainly to encourage the delegates. That's the reason it is called as Marathon CME. Now I welcome our President, Dr. Ramani Devi Madam, for welcome address. And shall we go with the Tamil Thai Valthu or after welcome address, Madam?
We'll go with the Tamil Thai Valthu.
Yes. Chitrakala, proceed.
எத்திசையும் புகழ் வணங்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்த செயல்மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Good evening.
Ramani Devi Madam is the National Vice President of FOXI 2020 and ICOG Governing Council member from 2018 to 20. And now she is the TNFOG President and Patron President for TNFOG and Executive Committee member of the Endometriosis Committee. And Madam had a lot of posts. She was in CFOG, AOFOG, everywhere. She was the member in Endometriosis Committee, I think. And she has many awards, starting from 10 gold medals in UG and PG to Dronacharya Award in 2023, ISAR, and many publications. And Madam is going to become a PhD holder within 1 or 2 months, I think. Ramani Devi Madam, for welcome address. Milan Shah sir has also joined.
Good evening, Sampath Kumari. Thank you for your kind introduction. As a president of Tamil Nadu Federation of Obstetrics and Gynecology, I have great pleasure in welcoming all the faculties as well as the participants for this very important obstetric topic, that is multiple pregnancy. I have great honor to invite Dr. Milan Shah, who is the guest of honor today, chief guest today. Chief guest today, and Dr. Dr. Bharati as the guest of honor. Bharati Rajshekhar as the guest of honor. See, my laptop is going in between. I'm not getting the thing. And we have, as Dr. Sampath had told, this marathon CME, you have 3 sessions. Your session where the judges are Dr. Kartika as well as Dr. Revati Janagiraman. And we have 2 young yuvas, that is Aishika and Suganya. Aishika is from Tanjavur Society and Suganya is from Dharmaburi Society. And then we have the very important talk by one of our patrons of Tamil Nadu TNFOG, Dr. E.S. Usha, which will be chaired by Dr. Malati Prasad as well as Dr. Preeti Kumar. And the last session is a panel discussion on practical points in multiple pregnancy, which will be moderated by Dr. Shantirani of Theni. And we have many participants.
Many madams.
On TNFOG. On behalf of TNFOG, I have great pleasure. Over to Dr. Milind Shah.
Milind Shah CV. Madam, Saroda CV.
Dr. Milind Shah is the president of ISOPOP, Indian Society of Perinatology and Reproductive Biology, and member of Maternal Fetal Medicine Committee of TNFOG, president IMA Sholapur branch, chairman Safe Motherhood Committee, and then founder president of IHRF, honorary secretary general of Federation of Asia Oceanica in Perinatal Science, and then vice president of FOXI in the year 2011, and president-elect of ISPAT, deputy secretary general of Indian Society of Aesthetic and Regenerative Gynecologists, ex-chairman of Rural Obstetric Committee of FOXI, ex-managing committee member of IAGE, peer reviewer for the Journal of OBGYN, and past steering committee member of Asia Safe Abortion Partnership, professor and head of the Department of OBGYN, Gandhi Nada H Medical College, and he had visited many countries and he had delivered lectures almost in so many countries. And then he has authored a book on hypertensive disorders of pregnancy, pelvic organ prolapse, and contributed 20 chapters to various books and published many national and international scientific papers. I think no society is without Dr. Milind Shah as the member or some official post holder in that society, and I have a great pleasure to welcome him for today's program as a chief guest. Over to Dr. Milind Shah.
Yeah, thank you very much, Dr. Sampath Kumari, for all these kind words. I'm very sure there must be some internet, I think, some internet issue actually, because there is something appearing little, the not very proper as it is happening with Dr. Sampath Kumari. So thank you very much, Dr. Ramani Devi, for the kind words. It's indeed pleasure. I would say vanakkam to all of you, because I know that I had been to the Tamil Nadu Society for so many times, and recently Dr. Ramani and Dr. Sampath Kumari had heard my Parva Dipama, actually, when I sung that in Allahabad, and they said, yes, now you can speak Tamil as well. Am I audible or my voice is breaking?
Yes,
sir, you are perfectly audible, sir. Perfectly audible.
Yeah. Okay, so otherwise what I do, otherwise then I can put off my video and the voice will be more clear. But if it is clear, that's absolutely fine, I must say big thanks once again to all of you, Dr. Ramani Devi, Dr. Sampath Kumari, and Dr. Sarvana Kumar, for giving me this honor and inviting me, because triplet pregnancy, twin pregnancy, and all multiple pregnancy, they are very close to my heart. In fact, you cannot believe, just yesterday I spoke in Dhaka on the same in Bangladesh. Sunday I spoke on the twin pregnancy double trouble in Lucknow, and I said now again I'm going to have the same actually the discussion here as well in this Tamil Nadu actually the program. I'm really happy to see Dr. Bharti as well, who is going to add more light on the perinatology. And I'm very sure, Bharti, that this is what you need to do in coming 3-4 years for the FOXI and everyone. I'm really happy to see even Dr. Revati and Dr. Kartika on this platform, as well as Dr. Shanti Rani. I could see her and so many other actually the panelists and the speakers. Suppose I take all the names, it will, the time will get consumed with that only. Now, when it comes to the twin and multiple pregnancy, it's really a challenge. But two, three important messages are important. We need to update our all the clinician friends that we need to concentrate on the chronicity of the twin pregnancy. Once we do that, half battle is won. So this zygosity and chronicity always creates confusion amongst clinicians. And to avoid that, we need to train them in the first trimester find. I go little further and I always tell even to my actually the colleagues who are in the city of Mumbai or Sholapur that you please give us pictures also, because it is not necessary that everyone will get acquainted with the T sign or they are unable to see the intervening membrane, how thick it is, and interpretation may vary from person to person. So that definitely going to go but long way, because very recently you just cannot believe I got one dichorionic triamniotic pregnancy. Now look what a confusion, where patient actually wanted reduction, but now I need to do her singleton instead of doing the twin pregnancy what we do normally. So to avoid actually all these issues, one need to understand everything very in clear about the zygosity and the chorionicity. The next thing comes about the managing her to avoid the preterm labor, and that is again a definitely challenge. But I'm very proud. Rather, I always say with proud to my patients also. All the twin pregnancy came to my office, to my clinic. All of them they reached to the term pregnancy or the up to 37 weeks, because we emphasize this emphasis not only required for the medical management but the counseling. Suppose you tell not only patient but entire family about the importance of this prematurity, you quote some good examples. They definitely become so compliant and take care of that particular patient very, very clearly. So all that happens when it is done very aptly. And then at the time of delivery, the help of all actually the neonatologist friend, pediatrician friend is again very important. And we'll have to see that if at all she has got certain elements because of the vessel problems, we'll have to intervene. Now, even for the trap syndrome, you all know that the laser is now available in many cities, though it was a domain of only Delhi. Now, no, it's available in many cities, and we can definitely take advantage of it. Only it's our apt duty to see that the case goes to a particular clinic, and then definitely she can avail the advantage of doing the laser ablation of those vessels, and again she gets a good pregnancy. Certain dilemmas are still there, like when there is one baby with IUD, one baby with some abnormality like anencephaly, but those are the individual cases. Those need to be actually managed by individualizing that particular approach, and then only it becomes possible to see that what actually happens. Actually, I wanted to show you one very wonderful video of triplet pregnancy, which was shot by my daughter, Bela, who works in Indore now. And she gave birth to a patient gave birth to a triplet pregnancy, and three babies were of 2 kg, 1.8 kg, and 2.1 kg. Pregnancy went to 36 weeks, and when she delivered them, she shoot it so well, and the family was so happy. But of course, it required a lot of hard work to take that. And to our surprise, when she mentioned that none of the baby required NICU, that was really a top on that particular actually the opinion what she gave or what she told to us. I don't know how much time I do have, but is it possible to show that video, or should I keep it at the end of it? You can guide me, Dr. Sampath Kumari or Dr. Ramani Devi.
How many minutes video, sir?
It's 2 minutes, yeah.
You show, sir. You can
Then I'll have to share my screen. You'll have to tell, yeah.
Chitrakala, make him as a host.
Yeah, just give me 1 second. Yeah, I will just open that.
Milan sir will now play the video, and when he comes for August to Chennai conference, he will sing one song.
Definitely, yeah. Yeah, I'm going to speak again sing the same song which you both like, the
yes.
Tamil version of the yeah, that's Rivalli. Correct, yeah, very true. I'm just opening this. Yes, yeah.
You have been telling something about the twin pregnancy. I'll tell you my own story. I am a twin mother of twin girls, but diagnosed only on table.
Oh.
So that was some 39, 40 years back.
Correct,
Where
correct.
we did
Yeah,
not
correct.
have no scans, nothing.
Yes. And you must have managed it very aptly, I'm very sure, because these are very common stories in those days. Yes,
Yes,
very
sir.
true. Yeah.
Yes.
In those days, it
Did
used
you
to
make
happen.
him?
Yes,
Chitrakala?
ma'am.
Yeah,
Done,
yeah.
ma'am, already done.
Achha, already you have done that.
Share
Achha,
your-
okay. Then I'm just, my video is getting open. Just give me 1 second. I think it is rolling and yeah, it got open now. Yes. Yes. Yeah. Now I'm sharing that video to you. Let me see it runs. Yeah. Yes. Here it goes. Yes. Share. Now please tell me, is it run? It is seen?
Screen is seen.
Started, sir. Just give.
It will come in a minute, sir.
Yeah.
You have
Yeah,
started
yeah.
sharing the screen.
Correct.
It will
Correct.
come in a minute.
Yes.
There will be a time tab.
Yeah, yeah. Little 1 second. Yeah, correct.
Yes, sir. Seen, sir.
Seen? It is running?
No, you have to
Okay.
Just click on the button.
Okay, okay.
Yeah, yeah.
Yeah, it's running correct. Yeah, true, true. But I'm very happy to see the entire program as well as such a wonderfully designed. It's really very useful. I'm very sure to the all delegates.
Yeah.
It's seen now.
Yes, sir.
Thank you. So she's my elder daughter who is practicing at Indore now.
Oh, beautiful.
Thank you very much, friends, for this little allowing me to show this video. But you know what it gave to my practice as well at this age, practicing since last 35 years, that yes, what the pleasure patients they get in multiple pregnancy when they get the baby is definitely it's immense pleasure. But what is required is a good counseling to see that it goes to the term. So I congratulated my daughter and the son-in-law for doing this so well, because the patient refused for the reduction on religious ground, and which is very common story. You know that some of the religions they don't allow this fetal reduction of the MTPs, and that's how actually things go. So thank you very much once again, and I'm very sure we are getting ready. We need to listen to Bharti also. Thank you very much for this honor.
Thank you,
Nice,
sir.
nice,
Thank you so
Dr.
much.
Milind. I too had a
Thank-
similar experience with my daughter who had
Yes,
twin delivery. I delivered her
wonderful.
this
Yeah,
is C-section.
great. Yeah,
Nice to
definitely.
meet
When
you
I will
here.
come to Madurai, I will definitely see those babies for sure.
Sure,
And babies
welcome,
are in
welcome.
Chennai, not in Madurai. They are in
Ajay, she's in
Chennai. Now,
Chennai.
madam
Chennai.
is
Then
in
it's more
Chennai.
easy. I'm coming to
Yes.
Chennai now.
That
Yes.
time you can see.
Welcome.
Absolutely.
Thank you, sir.
Absolutely. Thank you.
Thank you.
Ramani,
Thank
madam,
you.
you can welcome
Next, I
Dr.
call
Bharti.
upon Dr. Bharti Rajashekar, who is the guest of honor for today. Chitrakala, Dr. Bharti Rajashekar is Bharati Nursing Home. She is the owner of that Bharati Nursing Home, President Kasoga, and KPMEA State Vice President, Indian Red Cross Hassan Director. She has organized the first Foxy Satellite Conference in 2006 in Hassan, organized Red Alert workshop by Dr. Pankaj Desai from Hassan Master Control Facility, organized Kasoga State Conference in 2010. She has been a Foxy Public Awareness Committee South Zone Coordinator, Preventive Oncology Committee member, Medical Equipment Drugs and Committee, trainer for Foxy Zira program, and Foxy HPV vaccination program. She is also the trainer. Apart from Foxy, she has held various positions in IMA of Hassan as a past president and past secretary of Hassan OG Society, and she got the president medal for topper in the final MBBS from in Madras University. Foxy rotating trophy as secretary HSOG, DT Tank Award twice as HSOG secretary and president, and so many awards she has won. And then her special interest is non-communicable disease, and special interests are adolescent health and high-risk pregnancy, preventing oncology, geriatric health in women, family welfare, and contraception. More than that, she is now contesting for the post of chairperson for Foxy election. So we welcome you, Dr. Bharati, to say a few words.
Thank you. And என்னுடைய எல்லா அக்காமார்கள் மற்றும் தங்கைமார்களுக்கு என்னுடைய மனப்பூர்வமான வணக்கம். இது எனக்கு புகுந்த வீட்டில இருந்து இன்னைக்கு தாய் வீட்டுக்கு வந்த மாதிரி எனக்கு ஒரு ஃபீலிங்ஸ் இருக்கு. ஏன்னா I have been born and brought up and educated in Tamil Nadu. So almost half of my life, I have 2 decades I have spent in Tamil Nadu, and my roots are there still in Tamil Nadu. So I believe that this is my own society and not it is part of TNFOG, but I feel very homely when I meet anybody from Tamil Nadu for that matter. I immediately start talking in Tamil. ஆனா தமிழ் கொஞ்சம் மாறுது இப்போ எல்லாம், but still I can manage to read Tamil. But at the outset, I would like to congratulate the entire TNFOG team under the guidance of Dr. Ramani Devi, Dr. Sampath Kumari, and Dr. Sarvan for this excellent idea of having this marathon, because this marathon is incorporating all aspects of that particular subject. And it definitely gives us a lot of insights into whatever issue is taken up, and the whole subject is discussed in deep, so that all the delegates and all the participants have a perfect view of the whole situation, and they will be able to incorporate this in their clinical practice and go ahead with giving better services to those women who come to us for whatever issues. And coming to multiple pregnancy, yes, when we started our medical practice, multiple pregnancies were seen only as twins, and these triplets and quintuplets and quadruplets were not seen much frequently. But as Dr. Milind, but today with the extensive use of ART, we do see, multiple pregnancy, especially twins, has become very common. Everybody is ready to face a twin pregnancy just like a singleton pregnancy. But we as practitioners need to know that it is not that simple. Even a twin pregnancy has its own complications, and there's an increased incidence of perinatal mortality and morbidity even in a twin pregnancy. So hence the identification and the management of the twin pregnancy, not only as clinicians, but also tell the family how to go about caring and what are the risks involved in a multiple pregnancy, or even if it is a twin pregnancy. And reminiscing whatever practice we were doing, it is very nice. I would like to say that way back in 1999, I had a series of triplets. Well, 2 of them were spontaneous triplets, and 2 of them came to me for a scan, and I saw they were triplets. And it is so nice that I was able to deliver. In those days, even sending them for fetal reduction was a little difficult for us, because we coming from a semi-rural area. And I managed to take these pregnancies to almost 34-35 weeks, deliver them, and in 1 year I had 5 sets of triplets. And I'm proud to say that today, just about last 2023, 3 of those girls who belong to a Mohammedan family, they came to me and said, "Madam, we were delivered by you," and all 3 of them are medicos today. They are all in medical college. All of them are in medical college. It was such a wonderful delight for me.
Good.
Yes,
I
and
know.
Yes, and there was only one who came with she was an ART patient and she landed up with quintuplets, but we were able to take them to Bangalore and do the fetal reduction. And then she had triplets, and those children are also in college now. So they're all almost 25, 26, 24, 25 years old. So that is the experience we people had. But today, with the updates in imaging, the updates in management, I don't think we need to be perturbed about management of multiple pregnancy, but we need to know what are the complications and how we need to care for them. And tender loving care was one mantra we used for all of them at that time. So I think in this marathon CME today, the topics have been well chosen, and we will be knowing, coming across what are the issues and how we could tide over them in our clinical practice. And I'm sure the panel discussion will be dealing with those points. And Dr. Usha happens to be my college mate, and her husband is my classmate, Dr. E. Sahadevan. So again, it is so close to me now, and she is doing a wonderful job in fetal medicine, and she will be talking to us about the imaging in multiple pregnancy. And then the two youngsters who are going to have, it's like going to be an oration where they are also going to compete. It's not a debate. And the idea, I think, flaunted by Dr. Ramani ma'am and Sampath Kumari ma'am to give them a prize and honor them in the annual conference is a wonderful, wonderful thought. And I've just written it down thinking that I could replicate that in my society as I stand as the Kasoga state president right now. And the other one was, which was very, very interesting and novel to me, was giving questions and then identifying who gives the fastest finger first, and they will be honored again by giving a small token of appreciation and prize in the annual conference. Excellent ideas you have. I wish this marathon finishing on time and finishing with all success. And we have many more marathons to run in the next coming months. And I thank TNFOG, Dr. Ramani Madam, Sampath Madam, Saravanan, Dr. Revati, for all of them for giving me a chance to be on this very, very interesting session today. I'm wishing the marathon a great success, and let us be associated in the future programs also. And as Dr. Ramani Madam mentioned, I am going for the FOXI Perinatology Committee as a chairperson. I humbly request all of you, my own sisters from Tamil Nadu, please support me. Let us have more faces in from Tamil Nadu and Karnataka in the globe of FOXI. And I wishing the success, the program a success. Thank you again, Dr. Ramani Madam and Dr. Sampath Madam. Namaste.
Thank you, Dr. Bharati. I think our secretaries and presidents of many societies of TNFOG are here who have joined. Kindly take out this point. Dr.
Yes,
Bharati, nominate Dr. Bharati, and also so many others from the south are contesting. Dr. Deepa Mukundan, Dr. Kasturi Donimat, Dr. Aruna Suman. So many of them are contesting. So let us all join together and try to bring as many as chairpersons from down south to get into the FOXI to have a working.
And we wish, Madam, we wish you, Dr. Ramani, we wish Dr. Ramani Madam the all success. She is going for the ICOG Vice Chair position, a well-deserved and the right person to be at the right place. Madam, we are all with you. I request all of you to spread the word and see that Ramani Madam sits on the Vice Chair of ICOG.
Thank you.
Yeah.
Thank you.
Yeah, all the best, Dr. Bharti. But during my speech, I forgot about this candidature. So, Dr. Ramani Devi, all the best.
Thank you, sir. Thank you.
And I'm very sure.
Your blessings will be there. I remember when I was on my way to Bijapur for a meet, Dr. Milind Shah, he forced me that you must break down at Cholapur and give a talk.
Yes.
Okay. So I did. And then the next day I went to Vijaypur. So though he was not available on that day, but all his president and secretary of the Cholapur Society, they took a good care of me, and I had the opportunity to meet them. Thank you, Milind Shah.
All the best. All the best.
Thank you, sir.
Revati madam, unga twins coming சாருக்கு பக்கத்துல நின்னுட்டாங்க.
Achara,
They are
they left for the dance class.
No problem. Okay. Thank you, sir. Thank you. We will start with the scientific session. Yes, first is our UA session. For that, I call upon Dr. Revati Janakiraman, madam. She was the past president of TNFOG 2023, vice president of FOXI South Zone 2016, founder secretary of and the past president of Madurai OG Society founder, president of IMS Madurai chapter, president MCOT, and a recipient of Oxy Durusha Community Award, Lifetime Achievement Award from IMA Madurai, and author of Oxy Focus Amniotic Fluid A to Z, and master trainer for PPIUCD by Foxy and Figo, contributed many chapters, and Pride of Foxy Award in November 2019 at Mumbai. Revati Madam, welcome Madam.
Thank you.
Sorry, today Kartika Prabhu. Kartika, have you joined? She is traveling in a train, I think, somewhere. If possible, she will join. She is the professor in SRM Medical College, and her special interest is high-risk pregnancy and gynec endoscopy, midlife health. Okay. Chitrakala, the juniors, Madam Revati Madam, நானே introduce பண்ணிட்டா நீங்க பண்றீங்களா?
ஒன்னும் பிரச்சனை இல்ல, யாருனாலும் சரி. Okay, the first speaker is Ashika Jobson. She's a consultant obstetricians and infertility specialist, Shenbagam Nursing Home, Pattukottai. She did her MBBS in Tanjore Medical College and MD in Raja Muthiah Medical College. She has done diploma in IVF and reproductive medicine, ICOG course in reproductive medicine also. Of course, she is a life member of Foxy, and she is much interested in reproductive medicine and high-risk obstetrics. And she is going to talk about chorionicity in multiple pregnancy and its significance.
Can I share my screen now?
Yeah. Start. And the instructions, you please tell somebody.
Ashika, 12 minutes presentation, 3 minutes question by judges. Okay.
Yes, ma'am. Good evening, respected judges, honorable professors, and dear delegates. The topic given to me was chorionicity in multiple gestation. So the content of today's topic is going to be introduction, risk factors, definitions, timing of cleavage, determination of chorionicity, significance, and conclusion. So more than one fetus developing simultaneously in the uterus is termed as multifetal gestation. The prevalence of multifetal gestation globally at present is 32 per 1,000 deliveries, whereas recent studies from India report an incidence of 30.5 per 1,000 deliveries. We all know the risk factors including race, family history, ovulation induction and ART, which is a major contribution right now, multiparity, use of OCPs, advanced maternal age, and previous history of multiple gestation. Before knowing to the topic proper, we have to know few definitions, which include zygosity, chorionicity, and amnionicity. Zygosity refers to the similarity between the genetic material in specific loci or alleles. In simple terms, it is the genetic similarity or dissimilarity between the twins. It can be either monozygotic twins or dizygotic twins. Monozygotic twins result from fertilization of a single ovum, while dizygotic twins result from fertilization of two separate ova. And monozygotic twins, the incidence is 1 in 250, while that of dizygotic twins is 1 in 80. The intervening membranes here in a monozygotic twin is only 2 amnion, and the thickness of which is less than 2 millimeter, while on the other hand, the intervening membrane in a dizygotic twin is 4 with 2 amnions and 2 chorions, and the thickness is more than 2 millimeter. Coming to sex, monozygotic twins are identical, whereas dizygotic twins are non-identical or identical. The genetic feature of monozygotic twins are same, while that of dizygotic twins are different. Coming to chorionicity, it refers to the number of chorionic cavities and placentas. It is derived from the Greek word chorion, which means membrane surrounding the fetus, and it is classified as monochorionic, which has 1 chorionic cavity and a single placenta, and dichorionic with 2 chorionic cavities and 2 placentas. Amnionicity in multiple pregnancy. The term amnionicity refers to the number of amniotic cavities. It is also derived from the Greek word amnios, meaning little lamp, or a vase in which the blood of a sacrifice was caught, or a membrane surrounding the fetus. In clinical practice, its determination is relevant only to monochorionic twins. So why to represent zygosity, chorionicity, and amnionicity? If we look at this picture, this is the zygote, and depending upon the division taking place at various timings, the resultant twins are of various types. So when the division takes place at 0 to 4 days post-fertilization, that is at the morula stage, the resultant twins is a dichorionic diamniotic twins, where there is a separate chorionic cavity and an amniotic cavity. And here, when the division takes place 4 to 8 days post-fertilization, that is at the blastocyst stage, where we can see 2 inner cell mass has already been formed. There is a stable chorionic cavity, but 2 amniotic cavity, which results in monochorionic diamniotic pregnancy. When the division takes place 8 to 12 days post-fertilization, the resultant pregnancy is going to have a chorionic cavity, and the amniotic cavity has already been formed. So it results in monochorionic, monoamniotic pregnancy. And rarely, when the post-fertilization takes place more than 13 days, it results in conjoined twins. So in simple words, when the cleavage takes place in 1 to 3 days, at the stage of morula, it results in DCDA twin. And when the cleavage takes place at 4 to 8 days at the blastocyst stage, it results in MCDA twinning. And when the cleavage takes place at 8 to 13 days of post-fertilization, where the blastocyst is already implanted with a formed amniotic cavity, it results in MCMA twins. And when the cleavage takes place 13 to 15 days post-fertilization, where the embryonic disc has already formed, it results in conjoined twins. So how to determine this chorionicity and amnionicity? There are various methods in determining the chorionicity and amnionicity. It involves ultrasound examination, macroscopic examination, and microscopic examination. Ultrasound evaluation is the best method in determining the chorionicity and amnionicity with 98% accuracy in the first trimester. Its sonographic features can be divided into before 10 weeks of gestation and after 10 weeks of gestation. So before 10 weeks of gestation, the key features are the number of gestational sacs, the number of amniotic sacs, and the number of yolk sacs. Number of observable gestational sacs, as we can see in the first image, there are two distinctive gestational sacs, which is indicative of dichorionic twin pregnancy. And here, in a single gestational sac with 2 fetal heartbeats is indicative of monochorionic pregnancy. Coming to number of amniotic sac, in a dichorionic pregnancy, it is always diamniotic because the 2 amniotic cavities are separate within 2 gestational sacs. And in a monochorionic pregnancy, if we see 2 amniotic cavities, it is monochorionic diamniotic. And if there is only a single amniotic cavity, it is monochorionic monoamniotic pregnancy. The number of yolk sacs is also a predictor of amnionicity. It may not be always accurate, as we can see in this example. This is an image showing a MCDA twin. We can see 2 separate amniotic cavity while there is only 1 yolk sac here. And this is the image showing a monochorionic cavity with one amniotic cavity, but there are 2 yolk sacs. So after 10 weeks, the features include sex discordance, number of distinct placentas, and the intertwin membranes. So coming to sex discordance, if a female and male fetus are identified in the late first or early second trimester, a dichorionic twin pregnancy is the rule. However, gender discordance is the biggest pitfall for the diagnosis of chorionicity. Coming to the number of placenta, if we visualize 2 separate placental masses, it confirms dichorionicity, as we can see in this image, but careful ultrasound evaluation has to be done in order to define the presence of a single placenta or 2 placentas in abutment. Excuse me, ma'am. Intertwin membranes. The intertwin membrane is a key feature in diagnosis of chorionicity and amnionicity. When we look at this image, when the intertwin membrane is thick and measuring more than 2 mm with echogenic with the placenta, it indicates dichorionicity. While the intertwin membrane is thin and less than 2 mm, it is indicative of monochorionic pregnancy. There are few signs which are also important in determining the chorionicity, like the twin peak sign or the lambda sign or the chorionic peak sign or the T sign. The twin peak sign represents dichorionicity and the T sign represents monochorionicity. Here in this image, we can see the lambda sign where there is a triangular projection of the chorion which is tapering into the intertwin membrane. And here there is no triangular projection of the chorion and there is a flat base indicative of the T sign. So even though ultrasound helps in determining the chorionicity, there are several pitfalls in ultrasound determination. As we have already seen that 15% of diamniotic twins have only 1 yolk sac. When it comes to placenta, there may be 3% of monochorionic placentas which are bipartite or bilobed, which may be mimicking dichorionic pregnancy. When it comes to discordant fetal sex, there are certain conditions where there are discordant fetal sex in monochorionic pregnancy, like sex chromosome mosaicism, monogenic disorders, ambiguous genitalia, and chimerism. And the intertwin membranes may sometimes show false positive and false negative lambda signs and may cause confusion. And there are entities like partial monochorionic monoamniotic twinning, which may also cause confusion. Coming to the next macroscopic examination, as we can see in the first image, the DCDA twin, the intertwin membrane is thicker and opaque. The chorion is firmly attached to the chorionic surface, forming a ridge. Whereas in an MCDA twin, The intertwin membrane is thin and transparent because it contains only the amnion, which is loosely attached to the chorion. And in this MC-MA twin, there is a lack of intertwin membranes, or sometimes it might have incomplete biamniotic septum. Coming to the microscopic examination, on histological examination, the first image shows the absence of the chorion in between the two amniote layers. So this is a monochorionic pregnancy, whereas this picture shows amnion and the intervening chorion with the connective tissue, and this is the amnion, which is the indicator of dichorionic pregnancy. So there are also new predictors of chorionicity. This is a cleft sign, which is an indicator of chorionicity in the second and third trimesters. So the first image is showing a cleft in the placenta, which is indicative of dichorionic pregnancy. This is an image of a 30-week pregnant patient, and the absence of this cleft sign within the placenta is indicative of monochorionicity, which is, this image is a 29-week pregnant patient. And there are also other methods of determining the chorionicity. This study promotes that single nucleotide polymorphism based self-read DNA testing is also a non-invasive assessment of zygosity, but future research is required to emphasize its reliability. So why this determination of chorionicity of much importance? Why does it all matter? So this is a study taken from a hospital at Trivandrum. They conducted a study comparison between dichorionic and monochorionic twins in antenatal outcome, intrapartum outcome, and postpartum outcomes. From the graph, we can clearly see that monochorionic pregnancies are at high risk for abortion, congenital anomalies, TTTS, fetal growth restriction, and fetal demise. And comparing the intrapartum outcome, we can also clearly see that the monochorionic pregnancies have low UPGAR scores for both the twins, and in postpartum, the monochorionic pregnancies need more NICU admissions, and neonatal deaths are more with monochorionicity. Though we know that comparing singleton pregnancies, the multiple pregnancies have more complications like congenital malformations, low birth weight, preterm birth, perinatal asphyxia, etc. There are complications specific to monochorionic pregnancy like the trap sequence, TTTS, TAPS, and cord entanglement. And also, there is also a special entity called conjoined twins, which is a unique form of monochorionic monoamniotic twin pregnancy. And this results when the inner cell mass splits after 12 days of conception. And depending upon the degree of fusion, it is of various types. So all these dreadful and disastrous complications are related to monochorionicity, and hence the significance of chorionicity in multiple pregnancy is to prevent perinatal complications. The excess morbidity and mortality in monochorionic compared to dichorionic twins is mainly related to the angioarchitecture of the monochorionic placentation, which does not exist in dichorionic twin pregnancy. The rate of miscarriage and perinatal death is more in monochorionic twins than in dichorionic twins, and death of monochorionic fetus is associated with a high chance of death of severe neurological impairment in the co-twin. Genetic disorders and chromosomal abnormalities is also dependent on the chorionicity. So the importance of chorionicity does not end here. So the significance of chorionicity in management is also very important. And as obstetrician, we have to be double vigilant when it comes to management of monochorionic pregnancies. In form of antenatal counseling, the couple has to be counseled regarding the chorionicity and the outcomes regarding the antenatal surveillance, because monochorionic pregnancies might need the increased number of antenatal visits, increased number of serial ultrasound monitoring, and interventional procedures also rely on the chorionicity, because single selective fetal reduction or multiple fetal reduction and chorioamniocentesis, everything depends on the chorionicity. And also, very importantly, time and mode of delivery is also based on the chorionicity, because when it is a monochorionic monoamniotic twins, we deliver by 32 to 33 weeks, and the mode of delivery would be cesarean section. When it comes to MCDA twins, the delivery, the time of delivery would be 36 to 37, and the mode of delivery depends. If it is a complicated monochorionic diamniotic pregnancy, cesarean delivery would be ideal, and if it is a DCDA twin, the mode of delivery will depend on the presentation of the first twin. And also, the last but not the least, the place of delivery is also dependent on the chorionicity. Generally, all the twin pregnancies are to be delivered in a tertiary care center, but when it comes to monochorionic twins especially, it is better to refer early referral to tertiary center, where there are special obstetricians, well-trained obstetricians, and also a 24-hour operation theater setup with a efficient functioning NICU facility. So in conclusion, twin pregnancies are associated with poor perinatal outcome, especially in monochorionic twins. The early identification of chorionicity is essential to prevent perinatal complications. Identification of early complication, antenatal surveillance, management, and optimal timing of delivery is recommended. Steps to prevent preterm delivery, intrapartum monitoring, availability of expert obstetrician, and good neonatal care facilities are recommended. Therefore, to improve the perinatal outcome of twin pregnancy, determination of chorionicity plays a pivotal role. So these are my references. Thank you for the opportunity provided, ma'am. Thank you.
Very good. Well done, doctor. And one thing is that in the management, the last but one slide is very, very clear as to the significance of identifying the chorionicity. Okay. Especially in management part. Yes, Malti?
Hello. Oh, madam, no, sorry. My children.
Okay. Sorry, and madam, sorry. Mainly the management part, not only for deciding the time and place of delivery, but also management of TTTS, or when there is a selective IUGR, or one baby dies, or when there is a discordant fetal anomaly. So when you identify all these things, depending upon the chorionicity, the management decision is going to change. It is going to matter a lot. Okay, that is another thing. So anyway, also during the invasive procedures, what we are going to take up. Okay. So,
yes.
Put together, you have done very well. Nice.
Thank you. Thank you.
Shall we move on to the next speaker? So next, Dr. Suganya, Assistant Professor, Government Darbhubli Medical College, and she has finished her UG and PG in Coimbatore Medical College, and she is going to talk about complications in multiple gestation. Over to you, Suganya.
Respected delegates, professors, and judges, good evening to all, ma'am. Ma'am, shall I share my slide?
Yeah, sure.
Today, my topic is on complications of multifetal pregnancy. Before going into the complications, I would like to tell a few words about the maternal adaptations in multiple gestation. All the physiological changes are magnified in multiple gestation because of the increased placental and fetal masses and because of the increased hormone levels. There is hypervolemia because of the increased plasma volume expansion more than 50 to 60%. There is decreased peripheral resistance, increased cardiac output because of the increased stroke volume, and all these put together limits the cardiac reserve. So in normal physiological changes in the pregnancy is magnified by many times in multifetal gestation, and so the mother has to cope up with all those things, and they are the most important causes for the maternal complications in the multiple gestation. So this is Dr. Anjita. She's an obstetrician. She succumbed to because of the complication of multiple gestation. She succumbed to the complication in the multiple gestation some 2 weeks ago, and it is a really haunting thing for any obstetrician who comes or hears about this adverse event. So we have to be cautious whenever there is a multiple gestation. All the parents will be doubly happy, but the obstetrician, we must be doubly vigilant and to identify the maternal complications and other fetal complications as early as possible. So all these maternal complications are the result of exaggerated physiological changes. There is more chances for gestational hypertension, gestational diabetes, anemia, pulmonary edema, heart failure, PPCM, and operative vaginal deliveries, postpartum hemorrhage, and finally hysterectomy or even maternal death. So I will go through one by one. So first, the antepartum complications. The antepartum complications in the first trimester is mostly the hyperemesis because of the increased serum beta HCG level, and spontaneous miscarriages can occur, and vanishing twin can occur, which is more common in the monozygous twins. In the second trimester, where most importantly is the gestational hypertension and the preeclampsia, it is almost 2.6 times higher in twins and furthermore in triplets. The incidence of gestational hypertension is 14% in twins. Yes, ma'am.
Can you go for slideshow?
Yes, ma'am.
Full screen. Yeah.
Yes.
So gestational hypertension and preeclampsia is 2.6 times higher in twins and furthermore in triplets. And the incidence is about 14% in twins, 21% in triplets, and 40% in quadruplets. This preeclampsia, it occurs earlier and with great severity. And the in multiple gestation due to ART, they are at increased risk of hypertensive complications. And all these are because of the imbalance between the anti-angiogenic and pro-angiogenic and anti-angiogenic factors. So there is increased level of anti-angiogenic factors like the soluble FMS like tyrosine kinase levels 1 and soluble endoglin, and the decreased pro-angiogenic levels like placental growth factor. So the ratio of them is also increased. All these things are altered even the normotensive A in mother with multiple gestation. Any mother with multiple gestation, at present she is normotensive, but even in her the blood levels, these angiogenic factors are imbalanced, putting them more at risk. So they have higher incidence of eclampsia and pulmonary edema and abruption. The other complications are anemia. It occurs because of the increased demands in iron and folate, and dimorphic anemia is common. And GDM is common because of the higher HPL levels, PPROM and preterm labor. And acute fatty liver of pregnancy, though it is a very rare complication, but among the acute fatty liver of pregnancy, 14% of the cases are reported in twin pregnancies. So in the third trimester, more from the second trimester to the third trimester, apart from the previously told all high risk complications, the cardiac complications are more. There is progressive diastolic dysfunction, and the incidence of cardiac failure in PPCM is more, and their pulmonary edema is also high. See, the PPCM is a diagnosis of exclusion, and the most common causes attributed are because of the viral myocarditis or the autoimmune. But coming to relating to our topic, the most common thing PPCM occurring in multifetal gestation may because of the aberrant response to the greater hemodynamic burden in the multifetal gestation. And it is said that the anti-angiogenic factors, SFLT, that is the soluble FMS like tyrosine kinase 1, it worsens the myocardial damage, and it is abundantly seen in multiple gestation also, and multiple gestation with preeclampsia. So PPCM is significantly linked with multiple pregnancy and hypertension. So this is one study which has been done in Japan, where the maternal cardiac function in twin pregnancy and one preeclampsia have been identified. See, this is the first graph where the twin pregnancy without preeclampsia, and the blue one is showing the twin pregnancy with preeclampsia, where the ejection fraction have been progressively decreasing, and especially this PPCM occurs mostly in the postnatal period also. So see here, even after 1 month after delivery also, the left ventricular ejection fraction is progressively decreasing. And this another one is graph is showing this another one graph is showing the E by E ratio, that is the left ventricular end diastolic pressure has been measured. The left ventricular end diastolic pressure is significantly rising in twin pregnancy with preeclampsia. So it means that the left ventricular diastolic function is being reduced. And all these are putting the mother at high risk for PPCM. So the conclusion what they have identified with this study is that twin pregnancy with preeclampsia or without preeclampsia should be considered as a high risk group for cardiac dysfunction, especially from the late stage of pregnancy to the early postpartum period. So this is one case report where they have identified one peripartum cardiomyopathy in a woman with preeclampsia and twin pregnancy. Actually, it was a study where they have identified all twin mothers with or without preeclampsia. They have been continuing doing the cardiac function. Echo has been done in frequent intervals, like 2-week intervals. So this is the first case where the cardiac function was serially monitored before and also after the development of PPCM. That is what we said. So the mother did not have any signs or symptoms of PPCM or any other things. Where here the mother has gained so much of weight, and the left ventricular ejection fraction has dropped down to almost 35% at 32 weeks of gestation. Even then, the mother did not have any actually symptoms of PPCM, but still they had done the elective C-section, and both the baby and mother were fine, it seems. So the earlier delivery here they have done, it has prevented the irreversible PPCM in this patient. Though they are not proposing this as a method of screening, but still the PPCM, how it occurs has been studied. And BPCM, after it has shown the symptoms, and we are identifying the stages of recovery, the chances of recovery is better when we are identifying it earlier. So peripartum cardiomyopathy is high in multiple gestation and also in multiple gestation along with preeclampsia. This is the pressure symptoms due to overdistended uterus. The mother may have dyspnea, edema, exaggerated lordosis, dyspepsia, and even obstructive uropathy. So these are the maternal complications that I have talked about in the antepartum period, and the maternal complications that can occur in the intrapartum and postpartum period. So in the first stage of labor, there can be prolonged labor and labor dystocia, and it might require augmentation. Malpresentations are common, and cord prolapse can occur. The second stage, there are high chances of operative vaginal deliveries, and cesarean section can occur, and abruption of the placenta in the second twin can occur. And in the third stage, it's more chances for atonic PPH because of the overdistended uterus, and retained placenta can occur. And in the postpartum period, there can be secondary PPH due to endometriosis and thromboembolic phenomenon, and psychiatric disturbances and lactational difficulties can occur. So coming to the fetal complications. The complications can occur in both monochorionic and dichorionic twins. So first, I'm talking about the complications which is common to both monochorionic and dichorionic is congenital anomalies, prematurity, and growth discordancy, and FGR. So congenital anomalies is twofold increase in twins compared to singleton pregnancy, and greater risk of cardiac anomalies are identified and more common in the monochorionic twins. So preterm labor occurs in almost 50% of twins, 70% of triplets, and 90% of quadruplets. So many things have been tried to prevent preterm labor and to predict preterm labor, but none of them have proven beneficial. So you can give vaginal progesterone, intramuscular or vaginal pessaries can be done. Cervical encerclage, on the contrary to the prayer belief, it is doing more. It is not doing good in preterm labor prevention. And tocolytics, beta mimetics should be avoided because it may increase the cardiovascular complications, and it may increase the tachycardia, and acute pulmonary edema can occur in multiple gestation. So next is the discordant growth and the selective FGR. So the growth rate of twins is equivalent to that of singletons in up to 32 weeks. Growth rate in triplets is equivalent to that of singletons in up to 28 weeks. After that, the growth acceleration is failed in later weeks because of the competition for nutrients. So the discordancy in twins is 13%, and the discordancy in triplets is 64%. And the incidence of complications like respiratory distress, intraventricular hemorrhage, seizures, sepsis, and necrotizing enterocolitis increase with the degree of discordancy. So what is growth discordancy is defined as more than 20% of difference in birth weight, or while measuring the abdominal circumference, when it is more than 20 mm between the two fetuses difference is also diagnostic of discordant growth. So why this discordancy occurs? This discordancy can be because of the difference in growth potential of the two fetuses, more common in the dichorionic diamniotic twins, and placental insufficiency, and sometimes fetal malformation or the chromosomal anomalies. So whenever we find a discordancy of more than 20%, it is associated with higher perinatal mortality. So what is selective FGR is, we have a discordant growth with Doppler changes. There are three types: type 1, type 2, and type 3. In type 1, we have the positive end-diastolic flow in the umbilical artery. In type 2, there is absent or reversed end-diastolic flow. In type 3, there is intermittent absent or reversed end-diastolic flow. So we have to go for serial ultrasound monitoring from 24 weeks of gestation for identifying growth discordancy and also for identifying FGR. In the FGR, type 1 and 3 are better than the type 2. Type 2 is very dangerous and it is omnious. Type 3 is more favorable, more particular for monochorionic monoamniotic twins, where there is intermittent alteration in the umbilical artery Doppler changes because of the cord accidents. So I've already told hypothermia, intracranial hemorrhage, respiratory distress, sepsis, and necrotizing enterocolitis are more common in the preterm neonates. And next, I'm talking about the complications unique to monochorionic twins. Monochorionic twins, the twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and twin reversed arterial perfusion trap. All these things are occurring because of the abnormal vascular communication and unequal placental sharing. In this picture, we can see this one twin is having only a very little portion of the placental territory, and also the umbilical cord is attached to the margin and to the one end of the placenta. Is also the of the territory, and this twin can get more nutrients. So it is because of all these complications are because of the abnormal vascular communications and unequal placental sharing. So this picture I have shown the twin. I have shown how the anastomosis between the two fetuses. There are arterial anastomosis, veno-venous anastomosis, and arteriovenous anastomosis. Here, the arterial anastomosis is most common and is about 75%, and it is bidirectional. And veno-venous anastomosis is almost 15 to 20%, and the arteriovenous anastomosis are around 5 to 10%. This arteriovenous anastomosis are the cause for twin-to-twin transfusion syndrome, and when they are unbalanced by these arterial anastomosis. Whenever there is an unbalanced transfusion between the two fetuses, it results in twin-to-twin transfusion syndrome. And this unbalanced transfusion occurs in the large central, deep anastomosis. So large central arteriovenous anastomosis, and they are unbalanced by the arterial anastomosis, and they are the cause for TTTS. So what are the changes? One twin will be supplying the blood to the other twin, and that is a donor twin. The donor twin will go for oligohydramnias, fetal growth restriction, pulmonary hypoplasia, and contractions because of the severe oligohydramnias. And the recipient twin will have polyhydramnias, circulatory overload, polycythemia, and thrombosis. So this is the quintro staging, where the stage 1 is anemia and polycythemia. The stage 1 is oligohydramnias and polyhydramnias. The oligohydramnias is the AFA should be less than 2 cm, and the polyhydramnias, the AFA should be more than 8 cm. And in the stage 2, here both the bladders will be visible. Both the bladder and the both twin will be visible. In stage 2 twin-to-twin transfusion syndrome, the donor twin bladder will not be visible, the other twin bladder will be visible. And in the stage 3 twin-to-twin transfusion syndrome, there will be changes in the Dopplers. In stage 4, the recipient twin will become hydrops with pleural effusion and ascites and all. There will be hydrops fetus. And the stage 5 is any one fetal will be the demise of any one, either of the one fetus. So this is the quintro staging in twin-to-twin transfusion syndrome. So management is mainly by the laser ablation of the vascular anastomosis. In this, see, this is the vascular anastomosis, and this is the vascular equator here. The vascular equator will be ablated by the laser by a Solomon technique, where this monochorion is dichorionized by the vascular ablation, and all the anastomotic vessels will be separated. So in this slide, I showed like the TAPS, that is a twin anemia polycythemia sequence. TAPS is a form of a mild form of TTTS, where the arteriovenous connections are occurring in the periphery and smaller vessels, and these are also unbalanced. So one twin will have anemia, the other twin will have polycythemia. So TAPS can be spontaneous or iatrogenic. Whenever the treatment for TTTS has been done with the laser ablation, the TTTS can resolve, and it may land up as a TAPS, twin anemia polycythemia sequence. So this is the slide showing twin anemia polycythemia sequence. The donor twin will become anemic, and the recipient twin will become polycythemic, and it affects almost 5% of the monochorionic twins. But the amniotic fluid volume, there is no major changes. So this is a picture showing one twin is a pale twin, and the other twin is a polycythemia, and the so antenatally TAPS may be diagnosed or may go undiagnosed, but the diagnostic point is MCA PSV. The anemic donor will have higher MCA PSV, more than 1.5 mom, and the polycythemic recipient twin will have lesser MCA PSV with less than 0.8 medians of multiples of median. Intrauterine death can occur in one or both the fetuses, and management is expected. But severe cases may need ablation of the communicating vessels by using laser. This is the next complication, where there is twin reversed arterial perforation, reversed arterial perfusion. It is only about 1% of the monochorionic twins. Here, one twin lacks the heart, and so it is a acardiac twin. The other twin has the heart and it has to pump for both the twins. So it is called as a pump twin. And the pump twin pumps the blood to the acardiac twin and the blood flows through the umbilical artery. And in the recipient twin, the umbilical artery flow is reversed. So that is why it is called as a twin reversed arterial perfusion. So the reversed blood flow, it goes towards the fetus and it preferentially to the lower half of the body. That is why the upper half of the body does not develop well. So the mortality rate is 50% for the donor twin due to cardiac failure. And if it has not been properly managed in the antenatal period, during deliveries, there can be difficulties. Even during delivery of the baby in the cesarean section, this acardiac twin can grow very big sizes also. So early identification and ablation is ideal. The monoamniotic twins, it is only about 1% of monochorionic twins and high perinatal mortality is there. The perinatal mortality is because of the cord accidents. Cord entanglement is high, congenital anomalies and preterm deliveries. So congenital anomalies, my earlier speaker has spoken all about that. And if there is not much of sharing of the organs, surgical separation can be done if necessary. Very important topic is single fetal demise. Single fetal demise can occur in the late second or third trimester. It occurs in 5% of twin pregnancies and it poses great risk for surviving twin. The causes for single fetal demise can be anomalies, placental insufficiency, infections, cord abnormalities, and twin-to-twin transmission syndrome. So single fetal demise can occur in both monochorionic and in dichorionic. In monochorionic twins, the sudden demise of one twin can cause sudden hypotension in the surviving twin. So the sudden hypotension will result in definite neurological damage and multi-organ damage. The result in but after identification of the one fetal demise in the monochorionic twins, immediate delivery, even if we attempt for immediate delivery of the surviving twin, but the neurological damage cannot be prevented because the neurological damage that has happened for this because of sudden hypertension cannot be reversed. So what are the other problems because of the sudden one single fetal demise can occur is preterm labor and coagulopathy. It's very rare. So management in the surviving twins in monochorionic twins, we can go only for close monitoring and deliver when it is more than 34 weeks. In dichorionic twins, we need not go for early decision to deliver. We can wait and deliver at term. We can do NST and biophysical profile in both the twins. Interlocking of twins, though very rare, can occur where one pole or body of the second twin obstructs the delivery of the first twin, and the second twin may be tried to push down from, but it's very difficult. The survival of first twin may be compromised, and so we can go by delivery by C-section when interlocking has been identified. So all these complications cannot be completely avoided, but can be managed. So first, whenever the antenatal mother comes to us and has been diagnosed with a multiple pregnancy, their joy is doubled, but the vigilance of the obstetrician should be doubled and tripled. And we have to first educate the mother regarding the complications and what all things can happen to her based on the chorionicity, how frequently she has to come for checkup and how frequently she has to go for ultrasound monitoring. And if it is a monochorionic twins, we have to tell her what are the complications that can be identified for the baby. And more than all those things, how she has to take care of herself and what are the maternal complications can occur also should be taught to the mother. In antenatal mothers with the multiple gestation, even the excessive weight gain is also a problem and a poor weight gain is also a problem. So how ideally she has to gain weight, what is the nutritional advice, all those things should be taught to the mother, and earlier diagnosis of the maternal complications and treating it, and the mother should be compliant, and the prompt decision and the timing and mode of delivery should be very, very essential. So any complication can be managed, but it should be diagnosed early, and only with the proper complaint of the patient, it can be treated well. And we have to advise about the postnatal follow-up also, because postnatally also she can develop many complications, including hypertension and PPCM. So postnatal follow-up of the mother is very, very important. And postnatal, she needs psychological counseling also, and postnatal advice regarding lactational difficulties also. Everything should be addressed, and we have to prevent and put an end to preventable maternal mortality. That is the most important thing. And we have to identify any complications earlier and bring the best outcome for both the mother and the fetuses. So thank you. So I take this opportunity to thank the TNFOG for organizing all these marathon CMEs, and also the Bodhana series is very much of a boon to all the PGs. It was very helpful for me, madam. So I thank the TNFOG, and I thank my HOD ma'am, Dr. Malavali ma'am, and my Chief Dr. Aditya Tamraselvi ma'am for giving me this opportunity and guiding me through this presentation. Thank you so much, ma'am. Thank you.
Thank you, Sukanya. Nicely done. Twin pregnancy is a double joy or double trouble. So it's a big question.
Yes,
and now, what do you think that the incidence of C-section for second of the twins? Why? And is it increasing?
Ma'am, the second of the twin, because if there is a cord prolapse and if the second twin is in transverse lie, and we are not able to do any internal podalic version or any other things, the chances for delivery of second twin C-section can be done, ma'am.
But nowadays it is increasing. But actually, when we were doing PGs, those days, there is absolutely no need at all. Anyway, the service is fully dilated and controlled ARM, and then you can just do an IP version and deliver it. If at all, if it is going to be a second, but nowadays the incidence is going to be around 10%. Now, again, TTTS, what is the success rate of laser coagulation?
Ma'am, in TTTS, the success rate is around 70%, ma'am. But the chances of going for TAPS is around 20%, ma'am.
Okay.
Following laser, the success rates we have seen, madam, for stage 2, the success rates are better, maybe 60 to 70%.
Malati, question is only for you, not for you. Malati,
No, she's just clarifying. Okay.
Spontaneously, it has come out of
It has come spontaneously. I didn't realize. Sorry.
Okay. Thank you. We can move on to the next session.
Yes. Thank you, Revati madam, and both the Yuvas, Ashika and Sukanya. Good talk.
They have done very well. Welcome, Preeti Kumar. Welcome, Preeti.
Thank you, ma'am. Thank you so much. Thank you.
Welcome, incoming Vice President in Kuprunga,
Okay.
madam.
Incoming Vice President Foxy. Okay.
Okay. Now we will move on to the second session. Ramani madam, நீங்க சொல்றீங்களா? நான் சொல்லணுமா?
நீங்க சொல்லுங்க.
So we move on to the second session. That is an update. The talk will be by imaging in multiple pregnancy by Dr. E.S. Usha. For that talk to chair the session, we invited Dr. Preeti Kumar, Chairperson Maternal and Perinatal Committee CFOG, and Chairperson Safe Motherhood Committee Foxy, Committee Member of MFM Committee AOFOG, Joint Secretary India Gestosis Chapter, and Vice President Lucknow OG Society 2022. And she is the recipient of many awards. Of all this, she was the North Zone coordinator for
Adolescent Health Committee.
When I was the committee chair. She did a wonderful work. I request all our South Zone and Tamil Nadu people to vote for her. She is contesting for Vice President post from North.
Thank you, ma'am.
Dr. Preeti.
Thank you, ma'am. Am I audible?
Yes, you are audible. Next chairperson is Dr. Malati, our own Malati. She is doing a series of imaging science classes every month on 3rd Saturday. She is the past president of Trichy Society. Madam, 1 minute.
Secretary.
Madam, past president of Trichy Society, Dana, madam.
President.
She was both secretary and president.
Yes. Past president. Innovati president, I Malte. Then what's won the first prize for fetoscopic skin biopsy in epidermolysis bullosa in national conferences, and best paper prize in UAFOXY, consultant in maternal and fetal medicine in TFMC IS Hospital Trichy, FMF certification course for first trimester ultrasound. She has many publications to her credit, and conducted fetal medicine workshops in South India and invited faculty in ASUOG and UAFOXY. And Dr. Preeti and Dr. Malati can take over.
Thank you.
Welcome, Dr. Preeti, ma'am. How are you?
All well, Malti. Thank you so much.
You want to introduce the speaker?
Yeah, I want to introduce the speaker.
Please do it.
So at the outset, let me thank Dr. Ramani ma'am
Anna,
and
hotspot
Dr.
wala ka?
Sampath Kumari ma'am. I think these two are, very close to my heart. And Dr. Revati ma'am, when she was vice president, we used to, love her academic sessions. Thank you. And it's always pleasure and honor to share the dais with my dear friend, Dr. Malti. She did a wonderful job when we did Tainalam at Trichy. She was the president of that society. So thank you so much for inviting me, and wonderful talk by the previous speaker. And we move on to the next session, that is imaging in multiple pregnancy. And for this, we have a very eminent faculty, Dr. E.S. Usha. She's senior fetal medicine specialist and consultant in high-risk obstetrics, more than 30 years of experience at Lotus Multi-Speciality Hospital. She's past president of EOGS, member of ISUOG and FOXY, faculty in National Fetal Medicine OBGYN conferences and workshop, and she had been conducting regular training programs for ultrasound and colposcopy. She's also doing a Rotary volunteer work for performing high-risk gynec surgeries in Nigeria every year. So welcome Dr. E.S. Usha, and she will be speaking on the imaging in multiple pregnancy. Over to you, Dr. E.S. Usha.
Just a minute, I'll just share my...
Ma'am, have you, any of you have seen twin pregnancy, tubal twin pregnancies?
No.
Tubal twin pregnancies.
Same tube, one uterus.
Still is
Yeah,
bad.
but
It's
we
raining
had
here in
one-
Trichy.
We had
Open
one case with twin pregnancy in tube. That was an IVF conception.
Both tube.
And single tube twin.
Single tube twin.
So that
I
was
have seen
published.
in both tubes, each tube having a single.
Yeah.
How is the weather in Lucknow, Preeti?
Very hot.
In Trichy, it is raining.
Oh, beautiful.
Trichy is always different.
On and off.
Oh, but
Because the heavy
today
rain.
it is good.
Yes, Usha madam has started.
Yeah, all
Okay.
cute babies.
First of all, let me thank Dr. Ramani and Dr. Sampath for giving me this opportunity. I think gone are the days like when Dr. Ramani delivered a twin diagnosed only in the table. Now I think we are diagnosing twins early in the first trimester, and imaging becomes the cornerstone of managing these multiple pregnancies. So we'll see about the chorionicity, dating, how we go about doing down screening, how to do the anomaly screening, and how to manage the discordant anomalies, the growth problems, and the problems of a sharing placenta. So Dr. Ashika has already told us that zygosity means the number of ova that are fertilized, and the chorionicity means the number of placenta what we have. And depending on the different timings of division, we have different types of placentation in monochorionic pregnancy. And she has already elucidated how to go about in diagnosing the chorionicity. So when we have two separate placentas like this, our job becomes easier. Otherwise, we look for the lambda sign or the T sign. In case, we should always try to establish the chorionicity between 11 to 13 plus 6 weeks. So none of our scans be in the NT segment should go without labeling the twins, whether it is dichorionic or monochorionic. And in case if one is finding it very difficult to label, a second opinion should be sought with an expert. Still, if that expert is also not able to tell the chorionicity, then it is preferable to classify these pregnancies as monochorionic, because monochorionic pregnancies need more close monitoring. Then we move on to dating. So how should be dating done? This also should be done between 11 to 14 weeks of gestation, normally by going with the CRL of the bigger fetus. There is still some controversy whether to use the bigger fetus or a smaller fetus or the average of it. But a majority of people and even the ISUOG guidelines accept that you go by the CRL of the bigger fetus. In case if the patient has not seen, had not had any scan in the first trimester, and she lands up for a second trimester, early second trimester scan, then we will date the pregnancy by the head circumference of the larger twin. In case of IVF pregnancies, of course, if we have the oocyte retrieval date, we will calculate by that. Or if that's a fertilization, and because nowadays it is more common to freeze the embryos and then transfer them in the consequent cycles. In those times, so you have to calculate the embryonic age from the time of fertilization, and which day of the blastocyst is transferred. So how do we go about down screening? So in a dichorionic twin, it is like having two pregnancies. So the incidence of downs actually doubles in the dichorionic pregnancies. So here we measure the NT for each fetus, and then the biochemistry is measured. Then the risk is calculated for each fetus, depending on the risk is manipulated by the difference in the NT. So we give a risk for each fetus in case of a dichorionic pregnancy. But as in a monochorionic twin, here again we measure the NT for both fetuses and the biochemistry is done. But here we expect both the fetuses to be of the same genetic material, though there are some rare exceptions. So we average the risk of the Down syndrome and then we give a pregnancy specific risk. Here we need to remember one thing, because the discrepancy in the NT or the increased NT in one of the twin may be a pointer for twin-twin transfusion syndrome also. So this may result in a slightly higher false positive rate in a monochorionic twin in down screening. In case if we have a vanishing twin, if we don't see any fetal pole, then we can treat it as a singleton and go for a combined test along with the nuchal translucency. But in case if we have a fetal pole, the PAP values increase after the twin demise, and this will alter the risk calculation for Downs. So here we use only NT for risk prediction. In case if we have more than two pregnancies, a triplets or a quadruplets, the biochemistry is not standardized, so we will have to calculate the risk based only on the NT. Can we use cell-free DNA? Of course we can, but the detection rate is not as good as for singletons. The detection rate is for 94.4%. So in case if we have a screening test which comes as positive, then we need to do an invasive testing. So for doing an invasive testing in a dichorionic twin, we can do a chorion villus sampling for both fetuses, because taking the advantage of an early diagnosis, and if at all an abnormality is found, we can do a selective termination or whatever it is in an early gestation. But in case of a monochorionic twin, amniocentesis is preferred, because if you are sampling the placenta, we will get only one placental tissue. For doing an amniocentesis, again at 16 weeks, we will go back and image the fetus. In case if the fetus is concordant for growth and anatomy, then we presume that the genetic content is the same, and then we can, it is sufficient to sample one sac. But in case if there is a difference in the growth or in the anatomy, then you have to sample both the sacs. So if you have a discordant CRL or NT, or in case if you have a reversal AVAV in one of the fetuses and normal in other fetus, all this can be predictor of twin-twin transfusion syndrome, though the predictive value is poor. So if the NT discordance is more than 20%, the risk of TTTS and consequent IUD is 30%. If the CRL discordance is of more than 10% and the NT discordance is more than 20%, then these pregnancies need detailed ultrasound assessment and test for karyotypic abnormalities. One word here, if you have seen a CRL discordance at an early gestation, that is between 7 to 10 weeks, it is a predictor for risk of single fetal demise. So we may have to scan them a little earlier than the NT scan. So coming to the anomalies, the structural anomalies are little more common in twins than in singletons. Though dichorionic pregnancies, it is same risk per baby. So it will be double than a singleton. But when it comes to monochorionic twin, because of the process of splitting, the chance of anomalies are increased 2 to 3 times. The CNS, cardiovascular abnormalities top the list, and GI abnormalities and the ophthalmic anomalies also more common in twins, monochorionic twins. Even though we expect the monochorionic twins to have the same genetic content and we expect the anomalies to be concordant, but majority of the time these abnormalities are discordant, except chromosomal anomalies in monochorionic twins. So in case if we have discordant anomalies, how we go about it? We need to think about doing an invasive fetal chromosomal and genetic testing, depending on the abnormality what we have diagnosed. And the management of discordant abnormalities depends on the chorionicity and type of anomaly. if the condition is lethal and it carries a high risk of intrauterine demise, in case of a dichorionic twins, we can just do a conservative management because we are not bothered if one fetus dies in the case of a dichorionic twin. But in case if it is a monochorionic pregnancy, we don't want the fetus to die in utero. So we need to think about doing a selective fetal reduction. If we have a lethal condition and it is not going to end up in IUD, but it's going to end up in a neonatal mortality, then probably we can go in for a selective, conservative management. If you have a lethal abnormality, but there is a risk of polyhydramnias, say for example, if you have anencephaly in one of the fetus, then this may compromise the gestational age of delivery because the polyhydramnias may lead on to the increased incidence of preterm labor. So here again, we have to think about doing a selective fetal reduction. So how do we screen for preterm birth? So we all know for screening for preterm birth, we need to do a transvaginal scan and clearly visualize the external os and the internal os and measure the distance between these two. So in case of a multiple pregnancy, a measurement of less than 25 millimeter at 18 to 24 weeks of gestation is a moderate predictor of preterm birth before 34 weeks. Having said that, there is still no consensus about how to manage these pregnancies in case if you find a short cervix. So coming to the growth, when we monitor the growth, there may be a selective fetal growth restriction. That is, one of the twin may be growth restricted. So how do we go about diagnosing selective fetal growth restriction? In case of a monochorionic diamniotic twin, at least 2 out of the 4 contributory parameters should be present. So this is from the Delphi consensus. So if you should have one of the twin estimated fetal weight to be less than 10 centimeters or the abdominal circumference to be less than 10 centimeters. If you have an estimated fetal discordance, it should be more than, estimated fetal weight discordance should be more than 25%. And you should have an umbilical artery pulsatility index, which should be more than 95%. So if you have 2 of this, then you classify it as a selective fetal growth restriction. So how do we calculate the discordance of estimated fetal weight? That is A minus B by A into 100. A is the weight of the larger twin, B is the weight of the smaller twin, and then calculate using this formula. In case of a dichorionic pregnancy, at least 2 out of these 3 parameters, here the abdominal circumference criteria is taken away. So it is estimated fetal weight of less than 10 centile in one fetus, estimated fetal weight discordance of more than 25%, and umbilical artery pulsatility index. So whenever we are doing an ultrasound, more than when the second scan is being done, it is always good to plot your growth in the graph. So looking at this graph itself, we can tell the twin B, that is in the green color, is growing okay. But whereas the twin A, there is a drop in the growth rate. So you go back and use this criteria to tell whether it is selective growth restriction or not. So this has already been told by Dr. Suganya. So when you monitor these pregnancies, we need to monitor using the umbilical artery Doppler as a cornerstone. So there are 3 types of umbilical artery Doppler findings. In type 1, there is always some positive end diastolic flow. In type 2, there is an absent or a reversal of end diastolic flow, which is constantly seen throughout the examination. In the type 3, there is an intermittent absent or reversal of end diastolic flow. So for some time, you see it having a positive end diastolic flow. After some time, there is a reversal of the end diastolic flow. This is mainly because of the consequence of a large arterioarterial anastomosis. So what does this signify? In type 1, where you have some amount of positive end diastolic flow, it has a better prognosis. These babies have lesser weight discordance, and there is a lower risk of intrauterine fetal death or parenchymal brain lesions. Type 2 has the worst prognosis because we know there is continuously there is absent or a reversal of diastolic flow. There is more weight discordance and deterioration of growth restricted fetus. But type 3, because of the arterioarterial diagnosis, they have an atypical clinical course. You cannot tell whether it will behave like a type 1 and give a better outcome, or it will behave like a type 2 and give a worse outcome, because the sudden intrauterine fetal death in small twin can happen in about 15%. And even if there is no intrauterine fetal death of the smaller twin, this fetus can have a parenchymal brain damage in up to 20% of the fetuses. So this makes counseling very difficult when you get a type 3 umbilical artery pattern in a selectively growth restricted fetus. In case if we have a dichorionic twin with selective fetal growth restriction, then because there is no inter-twin anastomosis, there is a negligible risk for the healthy co-twin. So the frequency of ultrasound surveillance and timing of delivery depends on the severity as well as the gestation age. So in case if you get a growth restriction in a very early gestation, probably we can give up on that baby and look for the better gestation age for the other healthy co-twin. So we need to aim to plan delivery, optimizing survival for both the twins. But the situation is different in monochorionic twins with selective growth restriction. So here, if it is type 1, we give an expectant management, follow up every week, and then if the umbilical artery Doppler worsens, we decide on delivery. But in case if it is in type 2 or type 3, then we need to look for the severity. If there are one or more criteria of this, that is, if the gestation age is less than 24 weeks, estimated fetal weight discordance is more than 35%, if there is a reversal of end-diastolic flow, or the DVPA also is increasing or it is reversed. So if there is none of these findings are there, then we can go for an expect management with follow-up of every week. But if there is any one of this criteria is met, then we need to think about actively managing these fetuses, because we don't want one of the fetus to die on its own with the consequent problems for the surviving twin. If there is a co-twin device which is happening before 14 weeks, that is like a vanishing twin, there is no developmental recommendation to the other twin. So we don't have to worry about the next twin. But after 14 weeks, there are complications. So the death of the co-twin can happen in 15% of monochorionic twin and 3% of dichorionic twin. Preterm delivery is a little more common both in monochorionic and dichorionic twins. And the most important thing is the neurodevelopmental impairment of the surviving co-twin, which accounts up to 26%. This again has been told by Dr. Suganya how this happens. Because of the sudden hypotension in the surviving twin, the neurological developmental impairment happens. So we need to do an imaging of the brain after 4 to 6 weeks, because this is the time it takes for the changes in the brain to be visible for us. And again, these newborns should have a neurodevelopmental assessment at the age of 2 years. So the problems which are specific to monochorionic twin, these again have been enumerated by Dr. Suganya. So this is the most common thing is the twin-twin transfusion syndrome, which happens in up to 35% of the monochorionic twins. This is because of the arteriovenous anastomosis. There is constantly the one twin is pumping to the other twin. So there is a decreased circulatory volume and decreased urinary output, resulting in oligohydramnios and growth restriction in the donor twin. Whereas the recipient twin gets increased circulatory load, there is an increased urinary output, which results in polyhydramnios. So we all know about the quintero staging. Of course, the staging is not very helpful in clinical management because not all stage 1 twins have a better outcome. And stage 1 doesn't become stage 2, stage 3, stage 4, and then stage 5. It can suddenly jump from stage 1 to stage 4. So, but still, we don't have any other staging system which is very helpful. So people are still using quintero staging. So how do we manage? The management depends on the quintero stage, the maternal symptoms and signs, and gestational age, and availability of the required technical expertise. So what are all the management approaches? Very rarely we can do an expectant management. The best outcome is with the fetoscopic laser ablation of the anastomotic vessels. Then in certain situations, we may do amnioreduction and selective fetal reduction. So in stage 1, nearly more than 3/4 of stage 1 cases have been reported to remain stable and regress without intervention. But still, of course, we need to remember that 1/4 of this may have problems. So what we do, we look whether there is any symptoms. and look for the cervical length. So if there are no symptoms and the cervical length is more than 25 millimeter, then we can monitor them serially with weekly, like a Doppler growth. And if it is not progressing, we can deliver them by 37 weeks. In case if there is a debilitating symptoms, like mother becomes symptomatic to polyhydramnios, or if the cervical length is shortening, then we need to think about treating these, as in case of stage 2 or 4. So in stage 2 or 4, if the patient is presenting to us between 16 to 26 weeks, laser coagulation of the communicating vessels is the first line of choice. If the patient presents to us after 26 weeks, or if there is no expertise available to do laser, then a serial amnioreduction may be tried. I think technical unavailability is not an excuse right now, because even though people may not be available in the own town, in the nearby town there are expert hands available. So we need to refer them to laser for a better outcome of the babies. So next is the twin anemia polycythemia sequence. Here, this can happen spontaneously in a monoclonal twin in 5%, but the incidence is more after laser for twin-twin transfusion syndrome. Because we know this is because of the smaller arteriovenous anastomosis, which are less than 1 millimeter, which allows for a slower transfusion of blood. So in case during treatment, laser treatment for TTTS, if one of the smaller anastomosis is not coagulated, then this can lead on to a twin anemia polycythemia sequence. And to diagnose, we always should do the MCA-PSV. So one fetus will show the anemia by showing an increased MOM, increased MOM for MCA-PSV. The other donor will have polycythemia, it will have less than 1 MOM. And the difference, or the delta MCA-PSV of more than 1, is also a diagnostic of twin anemia polycythemia sequence. So we may also have other symptoms. The placenta might appear bright and thicken in case which is associated with the donor twin, and it may be echolucent and thin, the portion which is associated with the recipient. And the polycythemic twin may also have a starry sky appearance of the liver. So how do we manage? If it is the difference is less, we can have an expectant management, or we may need to do an intrauterine transfusion for the anemic twin. Sometimes we may have to combine this with a partial exchange for the polycythemic twin. So if you have a discrepancy in the amniotic fluid, so one deepest vertical pocket is 8 centimeter, and there is a new classification that after 20 weeks, you should have the cutoff as more than 10 centimeter, and the other twin having a deep vertical pocket of less than 2 centimeter. So if it is so, then you classify them as TTTS. If there is no discrepancy, but there is a discrepancy in the estimated fetal weight, then you diagnose selective fetal growth restriction. If there is no discrepancy in the weight, but there is a discrepancy in the MCA-PSV, then we diagnose twin anemia polycythemia syndrome. But you have some differences, but this is not fitting into any of these, then you can go for an expectant management and do a strict follow-up and allow this to evolve into any of these conditions. So by serial monitoring, we can identify what is the condition. So a TRAP sequence, that is the twin reversed arterial perfusion sequence, which again happens in 1% of monochorionic twins. So we have a TRAP twin, that is an acardiac mass, which is perfused by the normal twin. So as Dr. Shivani has already told, the perfusion happens in the retrograde fashion. So normally in the umbilical artery, we are seeing flow away from the twin, away from the fetus towards the placenta. But here there is flow towards the twin in the fetal umbilical artery. So that is why it is called a reverse arterial perfusion. And because this pumping twin has to pump for both itself and for the acardiac twin, there is a hyperdynamic circulation, and there is leads on to cardiac failure in the pumping twin. So initial days we used to monitor, and only if the size of the acardiac fetus was increasing, we used to go for selective fetal reduction. But nowadays the trend is to do a cord coagulation, radiofrequency ablation, or interfetal laser therapy. just immediately after 16 weeks of gestation. So conjoined twin, again, we have seen many stories where we have seen conjoined twins being raised up in adult age group. They are undergoing surgeries and all. Nowadays, it is possible to diagnose them in the first trimester itself. So here we can see 2 spinal cords in this fetus. And of course, we can see a fused head also here. So if you are visualizing close or fixed opposition of the fetal bodies and fusion of skin lines at some point, we can diagnose conjoined twins. And nowadays, it is usually done in the first trimester. And of course, if we diagnose in the first trimester, the termination of these pregnancies happen most often. So the risk of brain abnormalities and neurodevelopmental delay is specific to monochorionic pregnancies because of the vascular communication. So this happens in fetuses which are affected by twin-twin transfusion syndrome, single intrauterine death, selective growth restriction, TAPS. So in TTTS, the risk of brain abnormalities happens in 5% for those who are undergoing laser coagulation. If you're doing serial amnioreduction, this increases to 14%. And if you're following expectant management, this may be as high as 21%. So this is one main reason why a laser coagulation is preferred in twin-twin transfusion syndrome. Moving on to fetal reduction. So fetal reduction may be of 2 types, where we do a selective termination. That is, you have an abnormality, like maybe a discordant anomaly or a very severe twin-twin transfusion. In these cases, what we do is the selective termination. When we have multiple pregnancy, more than 2, that is 3 or more, there is an increased risk for preterm delivery. So to reduce the risk of preterm delivery and to improve the perinatal outcome, we do multi-fetal pregnancy reduction. So when we do fetal reduction, what are the risks? Maternal morbidity is usually minimal, but there is a risk of miscarriage. So this risk of miscarriage increases with the initial number of embryos, with the number of fetuses reduced, and it decreases with operator expertise. So how do we go about doing multi-fetal reduction? Normally, we do a thorough examination of the entire pregnancy. So we choose whichever is technically easy. So normally it is done by the transabdominal ultrasound by all fetal medicine specialists. So here we select the fetus which is near the fundus because that is technically easy. In case if there is a fetus which needs to be reduced irrespective of the location, sometimes you may have a baby which is anomalous, or it may have an increased NT or an abnormal DV flow, then we need to reduce this fetus irrespective of where it is located. In case if you have a discrepancy in the CRL or in the Leica, then we choose the fetus which has the smallest CRL and the sac which has the least Leica. Now moving to the chorionicity, if you have, in case of a triplet, if you have trichorionic pregnancy, then it becomes, we can use all these criteria and go for fetal multi-fetal reduction. But in case if you have a monochorionic pair, then a dilemma comes whether to reduce the monochorionic pair and leave the singleton, because when we reduce 2 fetuses, there is an increased chance of pregnancy loss. Or we can reduce the singleton, leave the monochorionic pair, wherein we know the chance of complications related to placental anastomosis is more. So, but normally, routinely, we prefer to reduce the monochorionic pair and leave the singleton. So how it is done? It can be done either transvaginally or by using a transabdominal ultrasound. It has to be done with ultrasound guidance. So the transvaginal used to be done by the IVF specialist very early before 9 weeks of pregnancy. But nowadays, it is preferable to do more after 10 weeks of gestation, wherein we can ascertain the anatomy to a larger extent. So we use a 22 gauge needle with KCL, which is injected to the fetal heart or into the thorax, and then look for the cessation of the cardiac activity. Because of the small size, even if you are in the heart, we may not be able to draw blood from it. So why we prefer fetal heart? Because it requires only a small volume of KCL. If you are in the heart specifically, 0.5 to 1 ml of KCL will be enough to cause asystole. But if you are a little away from the heart, then a little more volume of KCL will have to be injected. So in case we have to do a selective reduction in the second trimester, In case of a dichorionic pregnancy, it is no problem. We can still instill KCL because there is no vascular anastomosis. So there is no problem to the other fetus. But in case of a monochorionic twin, the option of injecting KCL is ruled out. So we need to go for either bipolar cord coagulation, radiofrequency ablation, or a interstitial laser coagulation. Because in bipolar cord coagulation is technically little difficult, because most of the time we may have to go to the sac which has less amniotic fluid, then it becomes very difficult. In radiofrequency ablation and in laser, we aim to coagulate the, there's some disturbance, coagulate the intrafetal portion of the umbilical cord. So we coagulate the umbilical vein and the umbilical arteries just going in the fetal abdomen close to the cord insertion. So having seen this, so how frequently we need to do ultrasound. So in the dichorionic twin, we do a 11 to 14 week scan as in a singleton, wherein we do the dating, the labeling, chorionicity, and screening for trisomy 21. Then the one word, labeling, is very important in twins, especially when we have a discordant abnormality, a discordant NT, because if we have to identify the same fetus which has higher risk and then which we need to be terminated. So each center has a different method of labeling. So usually we label the twin which is closer to the cervix as twin A, and then go anti-clockwise to label the twins or triplets. And it is a good idea if you have a different placentas, it becomes easy to identify. Or you look for the cord insertion, then that also helps to identify the twins. So you have to have whatever number of factors you have, the differences between the two fetuses, use all those to label the fetuses. Then in a dichorionic pregnancy, the next scan can be done at 20-22 weeks for a detailed anatomy, biometry, assessing the amniotic fluid volume and the cervical length. Thereafter, every 4 weeks, we need to monitor the growth, amniotic fluid volume, and the fetal Doppler. And you can deliver after 37 weeks in case of a dichorionic twin. But in a monochorionic twin, we need to monitor them very frequently. So that is the importance of assessing the chorionicity very early in pregnancy. So at 11 to 14 weeks scan, it is the same as dating, labeling, chorionicity, and screening for trisomy. But starting from 16 weeks, these monochorionic pregnancies have to be imaged every 2 weeks. So look for fetal growth, the amniotic fluid, and also the umbilical artery PI. And after 20 weeks, we need to include the NCA-PSC also to diagnose there is twin anemia polycythemia syndrome. So in case if you find any abnormalities, then the frequency of monitoring becomes a little more, maybe every week or every 3-4 days. And the estimated fetal weight should be calculated, and the discordancy should be calculated and documented at each scan from 20 weeks. So a monochorionic twin has to be monitored very closely. And if you monitor these twins very closely, we will be able to give a better outcome for the babies. So these are the references I would urge all of the postgraduates to go through to get a better idea about monochorionic twins. That is the Maternal Fetal Medicine, January 21, the complications of monochorionic diamniotic twins, and the ISUOG practice. Thank you.
Thank you, madam, for the fantastic talk on twin multiple pregnancy. I think there's a question in the chat box. Would you like to take it, madam? How to calculate NT and CRL discordancy?
How to calculate?
NT and CRL discordancy.
Okay, you measure and you have the differences, and like the twin, from the larger minus the smaller one and divide by the larger one.
Generally, the software does it, so we are not much concerned. Software does it for us.
Yes, yes.
So you have to give the CRL of the large of fetus A and fetus B, and finally you get the discordancy if it is there. And if you find a discordancy in NT, then the risk of TTT is very high, isn't it?
Yes.
Discordance in NT, there's a risk of TTTs which is going to be high. Any other questions? Dr. Preeti ma'am, you want to add something?
No, I just wanted to say excellent talk, and I would like to have a talk in the north also. So I'll request Dr. Yes Usha, I'll soon organize one webinar, and please give one talk for north, north region also. It was really very informative. I also learned a lot of things. Thank you so much. Thank you.
Thank you, madam.
Thank you, madam. Thank you. Mrs. Radhika Gauri, will they go on to the next session on the panel? Are you there, Miss Dr. Radhika?
Yes, ma'am. Good evening.
Thank you, Preeti, Malati, and Dr. Usha. Now we will go to the question session. Question will be asked and the delegates can participate for this question. Preeti, thank you so much. Chitrakala, question. So the delegates can answer for this. Anomalous increase in simple questions only. This is just to encourage the delegates. Anomalous increase in monochorionic twins are 2 to 3 times increased, 4 to 6 times increased, 2 to 3 times decreased, same as dichorionic. Chitrakala, timings.
Yes, ma'am. I'm looking that, ma'am.
Yes, done, I think.
Seconds more.
Only one question. That is after panel, Chitrakala.
Yes,
Okay.
ma'am. Yes,
Now
ma'am.
we will
That's
go
after
with the third
session.
third session. This is about the interesting cases in panel. I hand over the mic to Dr. Radhika. Dr. Radhika has come from theatre.
Thank you.
Radhika. Take over.
Thank you. Good evening, ma'am. In all, ma'am.
Ma'am.
Yes, Radhika, introduce the moderator and the panelist.
Panelists. Okay, ma'am. Thank you very much, ma'am, for this opportunity. So next session is session 3, panel discussion. The moderators are, I request Dr. Shanti Rani ma'am and Dr. Bhanumati ma'am to moderate this session. Dr. Shanti Rani ma'am is a former professor and HOD Department of OG, Government TNFOG Medical College, and President TNFOG Medical Society. And she's got Best Doctor Award and Best Service Provider Award and Best Service Provider in Lab Sterilization. And she's also an organizing chairperson of colposcopy, OTCON, and Endogyne, and many conferences.
Thank you, madam. Thank you.
The next moderator is Dr. M. Bhanumati ma'am. She's a HOD and DNB coordinator, Department of Obs and Gynae, Sri Ramakrishna Hospital, Coimbatore. She has been, she's organized UFOXC South Zone 2019, and she got the travel grant recipient for the year 2010, International Gynecological Cancer Society. And she's been the past president of Coimbatore Obs and Gynae Society 2011 and fellowship of ICOG at 60th AACOG conference 2015. And she's got a distinguished alumni award by PSGR Krishnamal College for Women and active participation in national international scientific forums and publications. Welcome, ma'am.
Yeah.
Ma'am, can you please introduce the panelists? Dr. Gayatri ma'am, Shantirani ma'am.
Yeah. It's my great pleasure to introduce my panelist, Dr. Gayatri. She is a consultant of Shyamala Nasiyon Trichy and executive member of Trigos at Trichy Society. And the area of interest is high-risk obstetrics, infertility, and medical law. Welcome you, Gayatri.
Thank you, ma'am.
Next panelist, Dr. Vijayalakshmi Yanashegar. She doesn't need any introduction. And she is the professor in Department of OBGYN of ACS Medical College, Chennai, honorary treasurer of TNFOG 21, 22, 23. And her field of interest is high-risk obstetrics, adolescent gynecology, and infertility. Welcome you, ma'am. And next panelist, Uma Vaidyanathan. She is a consultant in Apollo Hospital, Trichy, and also consultant in Narul Hospital, Trichy. And Madam is an executive committee member of Trichy OBGYN Society. Written articles in the Journal of Trichy OBGYN Society. Her field of interest is high-risk obstetrics and laparoscopy surgery. Welcome, ma'am. And Dr. Lakshmi Ajit is the next panelist. She is the Senior Assistant Professor of Kanyakumari Medical College and she is the Secretary of NOX. Welcome you, Rashmi.
Thank you, madam.
And Anita Thamarichelvi, she is the Professor of Government Dharmaburi Medical College and also present President of OBGYN Society of Dharmaburi. Her area of interest is high-risk obstetrics and social obstetrics. Welcome you, Anita.
Good evening.
And to introduce the expert, Madam CV is not there. But you introduced already.
Already. Yeah.
Okay. Madam, I welcome you, Madam.
Yeah. It's nice to be associated in this meeting.
Thank you, Madam.
Yeah.
Thank you.
We'll start the panel. Welcome to the panelists. Yeah.
Shall I share my slide? Desha?
Yes, ma'am.
Yeah. Visible?
Yes.
Am I audible?
Yes, ma'am. Audible and visible, ma'am.
Okay.
Audible.
Okay. So I welcome you all for the today's panel discussion. I think all the part I wanted to cover is almost covered by the previous speaker. So I think it's easy for our job to fulfill the thing. And I welcome today's expert, Dr. Banmari Madam, and also welcome all the panelists who are all close friend of mine. This story of multiple pregnancy starts from epics, and we know there is an increased incidence, and already the speaker talked about all the risk. I want just to say that the mother is going to have all the risk, almost from A to Z in obstetrics. We used to teach the students like that. Anything you can tell from the obstetric book, that will be one of the complication of this multiple pregnancy, except for an post-term and macrosomia baby. That is very rare in multiple pregnancy. Other than that, whatever in the textbooks, you can tell in the exam and you can have a mark. And now, as everyone is telling that we have moved from the era of more surprises on table and OT, and now we have moved on to it is almost a multidisciplinary approach with the high technology of imaging techniques and also with the emergence of this fetal medicine. And now I can go to this is the patient with that 35-year-old primey with a history of 3 months amenorrhea. Patient not sure of her dates and has come to your OPD. On ultrasound, you discover twins. What all will you look for other things in the ultrasound? I think Madam, previous speaker, Usha Madam had dealt with everything. Gayatri, can you take up this case?
Yes, madam.
Yes.
Ma'am, once we see, ma'am, is it audible or is it?
Yeah, you are audible. You are very much audible.
Okay. Ma'am, since she is not sure of her dates, we'll have to take the CRL for both the fetuses. And usually the CRL of the larger fetus is used to, give the gestational age. And the earlier we find out the chorionicity, the more accurate it's likely to be. So the early pregnancy scan, looking for the lambda sign or the T sign, will be useful for us to tell about the chorionicity and the amnionicity. And it will be easier for us to label the baby as the one near the fundus closer to the cervix, or right and left. And these are the things in an early pregnancy scan I'd like to see.
And can you do a screening for preeclampsia, screening for aneuploidy at this time?
Ma'am, if it is between 11 and 14 weeks, we can go for an aneuploidy screening. And also screening for preeclampsia, we can always use the uterine artery PI, ma'am.
Yeah. Now she has come at the week of 12 weeks. So as you said, we can date, as you said, that is the larger of the two CRL.
45 to 85.
Account, and IVF, you can use the ET date. And after 14 weeks, if at all she comes, the larger head circumference should be used for dating. And regarding this chorionicity and amnionicity, we were talking about the thing first because once you take a first trimester, you had a chance to examine the patient. This is the most important thing to detect, because after this we are not going to label her as a twin pregnancy. We are going to say either it is an MCDA or DCDA twin. That is the more important thing. We cannot, as a layman, we cannot say she is having a twin pregnancy. And all these features, the two separate placenta, T sign and lambda sign, and number of layers, that's all dealt with the previous speakers. So I'm not going into detail. And labeling. We were talking about the labeling. That is the madam told you should have some consistency. Whatever way you are going to label, you should have some consistency. Closer to the cervix is named as, usually it's named as A, and away from that is B. Anything you have a consistency, and it should mark it as an A and B. That is the more important thing. And because she is at 12 weeks and she is a 35-year-old, you can go for an aneuploidy screening. And also screening for preeclampsia. So what is the importance of this uterine Doppler? You can take up, Gayatri, you can continue.
Yes, ma'am. Yes, ma'am. Ma'am, very, very important, because since she is a twin pregnancy, we know she is at higher risk of preeclampsia.
Okay.
And if it's going to be on top of it, we are going to have a uterine artery PA of more than 95 percentile for that gestation age. It becomes even more significant, ma'am.
Yeah. The thing is that if you detect that incidence of preeclampsia, she is a high-risk patient for preeclampsia with the justosis scoring and also with the MAP, along with the uterine artery Doppler, you can start aspirin so early. That is the thing I want to say. You can start aspirin 150 milligram at night earlier, because this will have evidence as per aspirin trial. It's going to prevent the incidence of preeclampsia.
The earlier we start, the better is our prevention.
Yeah, that is the thing. Ultimate aim of doing this ultrasound in this first trimester, that is between that 11 to 14 weeks, is to determine the chorionicity and label the pregnancy as DZA or MCDA. And also you can screen for preeclampsia and you rule out the aneuploidy. And now this patient ultrasound shows 12 weeks is a DCDA twin with a normal nuchal translation. Would you like to do any other test? Rashmi is there. Can you take
Yes,
up?
madam.
Yeah.
Madam, you can do the NT scan and the maternal age to screen for Down syndrome. I think that was already discussed. And for the risk for Down syndrome in monochorionic is per pregnancy, whereas the risk for dichorionic is per baby. Then you can go for structural abnormalities, because structural abnormalities are more common in twins. So you have to look out for structural abnormalities also. Then you can even go for screening for IUGR as early as 20 weeks. And it should
this period, we are talking about this patient. Now she's only 12 weeks.
12 weeks.
You want to do an biomarkers for this patient.
We can go for the double markers, ma'am.
Yes, ma'am. Double marker. Only the double marker is more like in case she has missed the double marker and if she comes in a second trimester, then probably you can go. Otherwise, there is no rule. Otherwise, there is no.
Okay. Now, in a case of vanishing twin or triplet reduced to twins, is the biomarkers going to be useful?
No,
or
it is not going to be useful. Only the NT should be done.
Yeah. If the vanished twin has a fetal pool, then you cannot order for this biochemical markers. You should take consideration only the NT and the maternal age, no biochemistry. And when the triplets are reduced also, we should go only with the NT and maternal age. Then non-invasive prenatal screening, testing in twins. This is upcoming.
Yes, madam, done. But the problem is you really don't know which twin is in trouble.
Yeah, that's the problem with biochemical marker also. But it is also, But this performance of the cell-free DNA, this is the guidelines from ACOG guidelines. The performance of screening of trisomy 21 is encouraging, but now the total number reported is very small. And it's not that much studies, it's a very smaller base studies, trisomy 18 and 30. So, but still it can be used in a case of twin. It has an encouraging results. So only for triplets and high order birth, we cannot use the still now at present cell-free DNA cannot be
We can use it, madam. If it is positive, then you have to go for confirmatory tests like chorionic villus sampling and amniocentesis. If it is positive. Okay.
Now for this patient, both NT scan and combined screen are normal. How will you manage this patient? What's the diet and supplements? And another panelist, Vijay madam is there. Uma is there.
Yes, madam.
Yeah, because it's come as a doctor, I couldn't make it. Uma,
can
can you
check
take
their
up this?
names.
So, what's the diet and supplements? Whether you will advise for bed rest, because all the things they have dealt earlier. So we can talk about some clinical aspects. Any diet you have to modify, supplements you have to
So
give.
we have to
will
add
advise-
because there is increased demand because there are twin babies are there. So the demand is more. We have to give more calories. For the singleton, if we give more than for plus 300 kilocalories from her non-pregnant diet. If it is for the twins, it will be more than 600 we have to take. We have to increase the kilocalories of proteins, carbohydrates, fats as well. And the gestational weight gain is also very important. And for the, depends upon the pre-pregnancy weight, we can tell the weight gain also. About 9 to 12 kg, it will be good weight gain. And dietary supplementation, because of the increased demand for the growing fetuses and also for the two placentas, we have to do increased demand for the iron, calcium, folic acid, magnesium, and vitamin D. So we have to supplement them also. 60 milligram of iron and 1 milligram of folic acid has to be given throughout the pregnancy for the increasing demands.
So she should gain the weight. Weight gain is more important. You should optimize the weight gain. She should not gain excess or very low.
Excess
so
or
that
low.
will have a very good perinatal outcome. And also definitely she needs additional calories and especially protein, additional protein, and should look for anemia. Anemia is the most common issue in a case of multiple
We have to
pregnancy.
give the iron-rich food is very, very important. We have to tell them which
Increase
are
the
rich in
dosage
iron.
of iron also. Folic acid, double the dose, and calcium
They
almost
continue.
2000, and all micronutrients should be supplemented for this patient. And the frequency of ultrasound, she is a dichorionic DCDA twin. Now we have done the dating, labeling, and we have done the chorionicity, and screening for trisomy has been done. Next, when will you advise for her to come for an ultrasound?
For 18 to 22 weeks for anomaly scan, madam.
Yeah.
And then we have to do a fetal echo as well. And then every 4 weeks, we have to assess the estimated fetal weight, like a volume, and also Doppler if needed.
At 20 weeks, you can also, around that time, you can also assess the cervical length also.
Cervical length also.
That's also possible.
Because
So
the risk of preterm labor is very high in twins, so we have to assess the cervical length. It's very important.
If it is a monochorionic twin, now our case is dichorionic DCDA twin, so we are asking to come after 4 weeks. Now, if it is a case of a monochorionic twin, we have seen her in the 11th week. Now we have assessed the gestational age, assessed the nuchal translucency and everything. What's the next visit you will advise for her to come?
16 weeks. At
Yeah.
16 weeks, we have to do
should
the
be
scan.
Monitored earlier.
From then on, every 2 weeks, we have to do a scan in monochorionic twins.
Yeah. Have to see this amniotic fluid, as madam said, fetal bladders. We are expecting TT.
Bladder.
Yes. When you are seeing the NT, we can see the discordance in NT. That's what madam was talking about. If it is more than 20%, then there is an incidence of TTTS is very common, and we are looking for the complication of TTTS in the case of monochorionic twin. So the ultrasound should be done very frequently, every
2 weeks.
days, every 2 weeks. And fetal echocardiogram should be done at 20 weeks. And 20 weeks, you can do an ultrasound measurement of the cervical length. And then
And
after
every
that,
time we have to do MCA PSV also to assess the anemia polycythemia sequence.
tabs. You can also look for an tabs. So this patient, this is the case one. That message is that chorionicity should be assigned, and we should label her And the patient should be considered or she should be called as which type of twin. After that first trimester, there is no telling that she is a simple twin pregnancy. And also you should screen her for a preeclampsia, and if needed, you should start her on an aspirin as early as possible. Now this is case 2. She is 32-year-old primey with 30 weeks MCDA twin with the ultrasound diagnosed intrauterine fetal demise of 1 twin. Vijay madam is there. Vijay Lakshmi madam joined. Anita is there. Anita,
Yes,
you can take up this case, no?
this is a MCDA
Will you
twin.
counsel the patient?
So the
It is a great blow, a traumatic experience for the mother when she
Yes.
suddenly we are telling that that's one
And
baby.
she's a 32 years old primey, so it's a very precious pregnancy for her.
Yeah.
And along with that, she's having an MCDA twin with one of the twin is death. And there is a more possibility that because of the sudden hypotension and anemia, the existing twin may have a multicystic encephalomalacia. So we have to tell them there is a possibility. It occurs immediately after the death. We can monitor the baby by fetal MRI can also be done. If it is, we can diagnose it, or else she can continue the pregnancy and we'll deliver it. After that, we'll see for any neurological deficit.
After 3 weeks, you can also go for an MRI. The counseling
MRI,
of the patient
fetal
is
MRI.
counseling of the patient is more important as an obstetrician. We are not a sonologist here. So we should explain the complications of preterm birth and what is the possibility of call for dates for this SDA babies. And also
we have to see if
30%
they are
of the
able to
surviving.
find out the reason for the IUD, ma'am.
Yes.
Yes, and if the reason is persisting, there is no point in keeping the other twin inside.
Yeah, if it is a background of preeclampsia, that is very rare in a case of MCDA twin. This usually happens due to vascular anastomosis. In a case of monochorionic, we are expecting. If it is a DCDA twin, usually it has a background of preeclampsia or some other causes, or it can be an isolated placental insufficiency in one of the baby. But as if it is an MCDA twin, it is more of an vascular. It's due to vascular anastomosis. So. When you counsel the patient about the neurological abnormality, you should say she is having a 30%. The other surviving twins have a 30% chance for getting a neurological abnormality, and unfortunately, the baby can die. Also, there is a chance for that of 50%, and you should counsel the patient regarding everything so that we cannot enter into the legal litigations in the later stage. And as she told, that is immediate delivery. It's not going to change the outcome. Only it's going to aggravate the condition because we are delivering as a premature baby, preterm baby. So we have to, whatever damage has occurred is already occurred. You can give the antenatal steroids. You can give even this neuroprotected Maxelf can be given to the surviving twin, whatever the best you can give, and monitor the baby. This coagulation profile is not that much important, but anyway, we have to do a baseline coagulation profile. And as Anita told, the termination is dependent upon the monitoring of the baby, surviving twin, and whenever is needed, Doppler changes. And this is not a usual problem in a DCDA twin because that baby you have to monitor, but you can prolong that. You can have an expected management till she gets into labor. The proper counseling of this case is more important. Then this is case 3. Vijay madam is there? Only okay. Then Rashmi is there, no?
Yes, madam.
Rashmi, Gayatri, Anita, and Uma is there. Uma is there.
Yes.
So Rashmi, you like to take up this case?
Okay, madam.
This is a gravida 2 with the previous normal delivery, 30 weeks DCDA twin. She comes with the early preterm labor. So we know that preterm labor is very high in this twin pregnancy than a singleton pregnancy. When this happens like that, can you prevent that? Can you advise bed rest and prophylactic progesterone or prophylactic cerclage or anything you can do?
Actually, we should be monitoring this patient quite in second trimester itself, right from 20 weeks. You should be doing you should be checking the cervical length. And if there is any history related indication, probably you can.
This patient has a previous normal delivery.
Okay, madam. Ideally, we should because there is a risk of preterm labor. We should monitor from the second trimester. And if they and we probably we could have prevented by vaginal progesterones or probably even a circlage could have been indicated for her at that point if seen the cervical length was less than. There is we should definitely try tocolytics for this patient, at least for the steroids to act and the and for
regarding
the
prevention. Or do you use this micronized progesterone to prevent that preterm labor in a case of twin pregnancy? What is your personal experience? Do you,
madam? We do.
Ma'am, I've tried for a lot of cases, and in most of them they went till term, ma'am. But then now the evidence doesn't say that they are useful.
Yeah.
What progesterone you are using, micronized or
no, ma'am. Initially, I used to use the 17-hydroxyprogesterone, ma'am. But ever since there was a controversy with that, I changed. But now I'm hesitating to use anything after these evidences, ma'am.
Actually, studies is going for 17 or for hydroxyprogesterone caprolite is compared to better than micronized progesterone.
Yes, ma'am.
Anyway, but at present there is no guidelines for giving this prophylactic progesterone in a case. As Rashmi told, when the cervical canal length is shortened, we are having a short cervix, you can go for either progesterone or cervical encircler. But Anita is done now. What is that when you are facing with a patient with cervical encircler done early in a case of IVF patients? What is your opinion regarding that, Anita?
Prophylactically, you're saying, ma'am? Prophylactic.
Yeah, all IVF pregnant women, when they are coming, they are already.
Yes, ma'am, it has to be avoided. It does harm.
Already they are dipped with progesterone and already there will be a stitch there, no?
Yes, ma'am. So it does more harm than good to the patient, ma'am. It induces preterm labor and it should not be done prophylactic circulation. It should be indicated, ultrasound indicated, or previous history of is there. It should not be prophylactic. Not done in all cases. It's not.
Okay. Okay, we are seeing a lot of patients, but
Yes,
still there is no robust study to recommend this progesterone.
We see many cases coming with circulage in preterm labor.
Okay.
It doesn't prevent
outcome. It's not preventing this. But
yes,
every patient of IVF is having a cerclage and also they are all dipped with progesterone.
Cerclage is only going to prevent our cervical incompetence. It has no effect on preterm labor. The problem with these girls are the over distension, where cerclage will not have any role at all.
And then what about this pessary? When it
No,
is
madam.
not due
No,
to
the same as that. The only thing is in cerclage, there is a risk of cervical trauma if they get into labor. In pessary, the risk is a little lesser. They are not going to injure this.
It's
Can
better
we have
than
an expert opinion on this,
if
madam?
at all the patient insists, I think this is better.
Yeah,
Madam, what is the expert
yeah.
opinion, madam?
Yeah. As you mentioned, a lot of IVF patients come with the already stitched and supported by the progesterone. But ideally, the evidence-based medicine does not recommend all this. And even in the shortened cervix, when you see and you predict, you're planning that it is going to be a preterm labor, the vaginal progesterone is the only thing nowadays recommended as an evidence-based thing. So the other things are all not really recommended. Even the pessary has not very much supported by the studies. That's it.
Thank you, madam. Thank you for the opinion. And also this studies also, as madam said, there is no recommendations and there is no robust study regarding that. And Anita, you told
Ma'am, the latest NICE guideline, ma'am.
Okay.
In the latest NICE guideline, since none of these preventive strategies are useful, they are doubtful whether we should recommend cervical length for prediction of preterm, ma'am.
Exactly.
Because the reason they have cited is when there is no way you can intervene, why should we see it and increase anxiety?
At least we can.
So it is against that periodical screening of the cervical canal length. There is no point. It's going to helpful
But
for
then
the outcome.
patients come, especially IVF patients,
But
they
usually
come for it.
obstetrician attitude, when there is nothing is available, something we can do, like that attitude, everybody is doing that progesterone and doing the cervical canal length.
Psychological handling and of the patient, ma'am.
Especially
there is
with
no
the
recommendations so far. So far, there is no recommendations. So we
Only
should wait
placebo
for
effect.
We should wait. Yeah, we can ask the patient to take this regular antenatal checkup and as counsel the patient regarding this preterm birth. And you can ask her to go for yoga, meditation, like that, so that she can have a better mental health to face all these problems you are going to say. So, as Anita told, the tocolytics are useful only to buy some time to give an corticosteroids and to give them magnesium sulfate, or you want to refer the patient to a higher center in utero. So tocolytics usually, what's tocolytics you are using? Uma is there?
Nifedipine, madam. Because the beta adrenergic agents will cause more harm than any benefit in this twin gestations because they can cause pulmonary edema. So we can use nifedipine is useful in twin pregnancies as tocolytic.
Atosiban and nifedipine can be used, ma'am. Atosiban is extremely expensive.
Yeah, atosiban can also be used, but it's extremely expensive, and we don't have. We are very
much experience
comfortable
in
with
that.
nifedipine.
So we are comfortable with the nifedipine.
With the nifedipine, so we are going with that. And the corticosteroid, as usual, we are going for Uma,
dexamethasone.
Dexamethasone.
We use dexamethasone.
Yes, dexamethasone. And magnesium sulfate, do you give for a neuroprotection for this patient?
Yes, madam. For 24 hours, 1 gram per hour. Dose infusion, madam.
Okay, it's almost like a suspense regimen of this eclampsia. We are following that. So this is the patient we are facing every day. This is a DCDA twin of 35 weeks. She is having no antenatal complication. Now you want to plan her delivery. When will you, the timing of the delivery and mode of delivery and the monitoring and precautions. I think 4 persons are there. Everyone can take the timing. Uma, you want to talk about the timing when you have to deliver her?
Because it's uncomplicated DCDA twins. We can wait for the, expectant management till 38 weeks, madam. After 38 weeks, there is a risk of, intrauterine death in these twins is there. So we'll deliver them by 38 weeks, madam.
Okay. Then uncomplicated MCDA twin, if it is an MCDA twin.
34 to 36 weeks, madam.
36 weeks.
If it is uncomplicated, we'll deliver them for
MCMA twin, it is an earlier, we have
32 weeks.
Then mode of delivery. Rashmi is there. Oh, mode of delivery.
Mode of delivery depends on the presentation of the fetus, madam. It is and the gestational age and the presentation and the expertise of definitely the expertise of the doctor also.
Yes, madam was talking about that previously we used to do internal podal equation. Now they are not doing this internal podal equation and all. So it all depends upon the skill of the operator also, skill of the obstetrician also.
And the patient's choice, ma'am.
Patient choice.
Yeah, patient choice.
I had a patient whose relative said both cephalic. No, because she was twin, she was on bed rest the whole of the time. We have not really walked or anything, so no normal delivery. You please do section.
Oh, okay. We can't do like that. I think so. Both cephalic, it's very difficult. If it is a cephalic and breech, at least we can go for this.
We'll feel a little better.
Yeah, both cephalic. First one is cephalic. Second, sometimes if we enter into complication with assisted breech delivery, at the time we'll feel sorry. But both cephalic, I don't think we should go by patient request. And the presentation, as you said, both cephalic, we usually go for an vaginal delivery because anyway, this patient, if they are going into anesthesia, they will definitely end up with a lot of anesthesia and post-operative complications.
Complications.
Vaginal delivery is the best for multiple pregnancy. And institutional
And
delivery.
be careful.
Institutional delivery. And this is the thing, this mode of delivery. Both vertex, we definitely will go for a vaginal delivery. And if it is the second is the non-vertex, it depends upon the obstetrician skill. Because if it is a breech, we have to allow for an assisted breech. If it's the transverse, we have to do an maneuvers. We should be well versed with an internal podalic version. We should need an anesthetist, general anesthesia. And both non-vertex, usually we go for an this thing. Because previous era, both the breech, they used to conduct these deliveries and all. Even I read a story from Bible yesterday. This 2 twins, the second of the twin delivered by holding this is maybe that religion people will be knowing this story, is on Jacob. The second baby delivered holding the knee, the ankle of the first. Maybe it's a compound presentation or a hand prolapse. So that story was there. So intrapartum monitoring. The next question is that Monitoring of the labor. Monitoring of the labor, Anita.
Yes, ma'am. Even before monitoring the labor, we should be very much ready with the blood for the. Here we do any twin pregnancy, we keep ready blood for the postnatal complication. Ma'am, intrapartum, we are more bothered about both the babies to be safe. So we have to monitor both the babies. Immediately after the delivery of the first baby, we have to look for the presentation of the second baby, and if possible we can even do an external cephalic version before the membranes is ruptured, and after that we can fix the head and we can deliver by vortex. Even before internal podalic version, we can try external cephalic version for the second baby and do a ARM and then deliver the baby with Sigdo if needed. And we should be more careful after delivery. There is more risk of postpartum hemorrhage. And we follow Amstel for all cases. After that also, we have to be very careful. As you said, after delivery, there is more complications of pulmonary edema if she is delivering by cesarean section. So we always have a fear of doing LSES for a twin pregnancy since they are very much prone for pulmonary edema. Like a preeclampsia case, twin gestation is more prone for pulmonary edema. So always it's better to do a normal delivery for a twin pregnancy.
Rashmi, if the second of the twin, you like to go for an external cephalic version or directly you want to go for an internal podalic version? You want to change the baby as external cephalic version, or you can go for an directly assisted breech delivery if the second of the twin is breech. What is your opinion, Gayatri? If the second of the baby is breech, she wants to do cesarean section.
Sometimes breech delivery is easier now.
No question. Government setup, doctor.
Twins.
You can tell.
Sometimes
Rashmi.
breech delivery for twins is easier.
Okay.
Most of the time, the twins delivery will be mostly preterm only. So the babies will be small. If the second twin is smaller than the first twin, and if the breech is already fixed, we can actually do an assisted breech delivery in
that will be
such
easier, no?
cases.
External cephalic version, you have to.
If the baby is
when
larger
the
than the first, it's better to go for cephalic version.
You want to go for an cephalic version.
If the baby is larger, expected fetal weight.
You want to go for an so because you have to give an tocolytics. It is not easy to do a external cephalic version when a patient is in labor.
After it is, yes.
You have to give some terbutaline or something, and then only you can go for an external cephalic version. It's a little difficult procedure, but you can still you are expertise in that. You can try for that. If you are expertise
I have
in
to monitor the fetal heart throughout the procedure, and also there is a risk of abruption is also there.
Yes, for that only I put the slide like you should
have
have
to
an
keep
ultrasound by
everything
the
ready
side.
for the cesarean inside by
Everything
while
should
doing
be ready,
that.
and you should have a real-time ultrasound always available. With that only we can conduct the delivery to do this all this thing,
A
and
lot
the
of time
CTG
it
monitoring.
if we are accurately monitoring both the heartbeats.
Yeah, CTG dual channel.
And the
CTG
ultrasound can be
monitoring is-
really handy.
Yeah, we can have a dual channel CTG monitor. It's everywhere available, even in government setup. So that can be done. So this is the thing I want to, as Gayatri said, the patient and the family should be counseled well because they want a cesarean section for both vertex, definitely. Then we counsel the patient regarding the plan of time and mode of delivery and to get an appropriate consent. And if something happens, then they will, according to that, this criteria, why you have done a cesarean unnecessarily for my daughter, like that also.
You have to get a concern that second twin sometimes may
end up with a cesarean. Yeah. Then sudden bleeding. Sometimes the cervix will suddenly close so that you can't even do anything for the patient. So sometimes it happens cesarean for a second twin. That's a combined procedure can also do. Induction of labor in a twin. Normally the twins oblige very well and they will deliver by time. Sometimes we need to go for an induction in a twin pregnancy at
police induction, police, mechanical.
Police will be better, ma'am.
Police
will be better. Okay. Then will you use oxytocin as such as an induction agent if the bishop's score oxytocin? That also have been done.
Yes, ma'am, we can.
Yeah.
We have to be careful about the drop rate. Better to
Yeah.
use an infusion pump.
Somebody should sit by the side of the patient and
monitoring of both the heartbeats.
yeah, you should sit by the patient when you are giving oxytocin. because I had an experience of sitting with the patient of twin when I did my post graduation. My HOD was Dr. Meenakshi. She asked me to sit with the patient. She delivered normally. So at that time, it was so prostaglandins can also be used, but actually it's a very risky to have a prostaglandin because once the gel has been introduced, we cannot take. Whereas oxytocin, it can be given as with all control. So contraindication for induction is, madam, you wanted to?
Yeah, oral prostaglandins has been suggested, and the recommendation is there, but only when there is a previous section that is really not indicated, but it is can be safely given. Usually, accepted the recommendations, it is there.
Yeah, madam. But Tamil Nadu government is not for this induction with
Yeah,
oral.
as per the law, they are not able to.
Oral misoprostol.
Yes.
Uma, do you have experience of using oral misoprostol in the case of singleton? I am not asking about twin.
No, madam, I have not used any misoprostol, but I used only the mifepristone gel. I mean misoprostol gel, madam.
Ma'am, it is very useful in ruptured membrane cases, ma'am.
PROMs, yes, ma'am.
PROMs, it is very.
Singleton pregnancies, oral is
Rashmi,
good.
do you use? Are you using it in?
PROs? Yes, madam.
You are using oral misoprostol.
Yeah.
And especially the twin gestations, they come even with the PPROM.
Yes.
And those patients really go for spontaneous labor, and ideally you can conduct normal. As somebody said, the babies are small and you can allow a vaginal delivery, closely monitoring. And after the delivery of the first baby, usually the uterus relaxes. I mean, not the frequent contractions occur. So you have an ultrasound and add as oxytocin if not good contractions are there, and then allow the presenting part to descend a little more down so that you can either cephalic or breech. You can do the maneuvers and then deliver the babies. That will be better.
Madam. Thank you, madam. Thank you for the expert. And Tola in twin.
She comes in spontaneous labor.
Ma'am, if we go by what is given in the evidence and guidelines, chance of success is quite okay, ma'am. But I don't do it, ma'am.
Okay.
No, it is very difficult to say because one is facing with a lot of difficulties. Even in a normal previous section singleton pregnancy, much of the VBAC criteria and the monitoring in the setup and how to go about that has to be followed. So in Tolak in twin, it's not contraindicated, but they said that the prostaglandins
It's very risky because of over distension of the uterus.
Yeah, prostaglandins are not indicated.
Already the patient is in labor and about to deliver, you can deliver her.
Yeah, if it is about to deliver, then we can deliver. If it is a preterm labor, 32 weeks, she has come and very small babies, it is already in active labor, then we can conduct with all monitoring of the
Again, if the second one has to be cephalic, all these manipulations are not allowed in a previous section.
No, when the patient comes in as spontaneous labor and she's getting proper contraction and everything is uncomplicated, I think we closely monitor and will be able to
closely monitor and deliver
as for the singleton also that you can monitor at it can be allowed.
It is both cephalic, I think we can allow both cephalic.
Allow spontaneous labor, it is better.
Previous cesarean with anomalies now or any other problems when they come, we have to induce.
We are talking about no comorbid, it's both cephalic. That can be done as, but honestly talking, we are not for that because we are very scared of this litigation issues.
Yes.
And this is the last case. I think time is there. Radhika ma'am, can I take up this case? This is primary TCTA. Triplet. Okay, only 5 minutes. Reduction or expectant management? What is that? All panelists can say. She is a primary. You want to go for a triplet. It's only trichorionic triamniotic triplet. You want to go for a reduction or you want to go for an expected management? Anita, what is your opinion? Anita, you want to go for a reduction or expected management? You can, just only Milan said showed a video. all triplets delivered very normally, cesarean section, all are healthy. So, what about your opinion?
We
Anita
should
is
talk to
rational.
the patients, madam. Parents, we have to ask the parents first.
Counsel.
And we have to tell them, counsel them, and then we have to tell the complications and
Very
the
high risk of,
difficulties and
preterm
economically
delivery.
also. There is more cost is involved in having this babies because preterm deliveries are more common in this, and complications are also more common.
So, if you
And
reduce the
everything have to
pregnancy,
counsel.
you could reduce
And
the
if they
pregnancy,
want to
there is a
reduce the
reduction in
pregnancy,
the
we can
preterm.
reduce it to twins. Yeah.
Maternal complications are reduced, lower hypertensive disorder, and this birth weight is very high, and you can have a reduction in the preterm delivery, reduction in the neonatal mortality. But as you said, patient option is more important. Patient consent is more important in this condition.
No,
Rashmi, what is your opinion? You want to reduce or you want to go for an expected man? I think she's.
Ma'am, as Dr. Uma pointed out, it's no longer what we think, ma'am. We are here only to teach the patients and they take their decisions.
Yes, yes. That is the thing.
No,
We have to talk about all the thing and they have to
All
take
the
their
things we
decision.
have to tell about the complications.
Otherwise, they do go for a preterm labor, we'll be blamed.
No. When we counsel the patient for this lady, the fetal reduction, you will be explaining regarding the fetal loss as well.
Yes,
So the
yes.
patient
Fetal loss
as well
also.
will be really thinking twice before I let me have all three, and I'll try to manage. As Milan Shah told, we have also done some triplets, which is very difficult, but you monitor every trimester closely, all the screening, everything to be done. Provided everything is going fine, you can it is as per the decision, combined decision with the patient. That has
Yes. We have to explain, we have to counsel the patients, we can talk about the pros and cons with that.
Pros and cons.
Yes. Everything should be discussed in this era, and then on day, it's better the patient herself or their family can take up the decision in this type of situations. And this is how the babies reduced reduction can be done. As this thing explained by Madam, already Usha Madam, so I am not going to into details. So now we are ending. Everybody is talking about double trouble. We'll make it as a double joy. Thank you. Thank you.
I just wanted to say a few things to all panelists have really done good job, and Dr. Shantirani, you're really selected it nicely because it's not a repetition of the things. You're really given the case scenarios. And when we had delivered, one patient with the quintuplets, and she was not willing for reduction, and one baby died in it at 16 weeks, one fetus. But she continued the pregnancy and monitored very closely. At 33 weeks, we could deliver that 4 babies in an OT with the 4 pediatricians and 3 anesthetists like that with a good team. But it is possible sometimes. It is not that every time we cannot be assuring the people, but it is very troublesome and burden. And sometimes after the baby at that point of time, the fetus papricious, you must really see and find out whether the it is there, because the reduced fetus we have to deliver. We should not forget, and it should be taken and identified in the placenta along with the placenta, which is like very sometimes mummified. It will be lying or stuck to one part of the uterus, so better to clear the uterus completely. And in our PG, when we were doing PG, there was one, as Dr. Raman Devi said, there was one undiagnosed twin. Usually the house surgeon gives the Cometrin. He gave, and by the time we could see the uterus is quite big and something bag of we all got, because the chiefs have gone, we really were worried where are we going to end. But I could see that whole en mass with the amniotic bag. It just as a capsule it came out for our luck. It is not that. So we nowadays we must see whatever it is, the abdomen palpation before anything is done. Now ultrasound is there. We are managing, identifying the twins, and it was a real elaborate session. We covered all the things in the regarding the multiple gestation. Very happy to be with us. Thank you.
This also happened in my post-graduation period when this ergometrin has been given without identifying the second of the twin, and Dr. AL was the director at the time. She told, when she was on the round, she told, at least you already you gave methadone, at least see to that what is happening for the patient. You can learn something, she told like that. So I'll never forget, and it's always better we can have a clinical material, always we should have, whatever the technology, imaging, everything. We should always believe in yourself, so that will be useful for that long-term practice. That's what we have traveled our journey, I think. Okay.
We could see the in utero structure, I mean, fetus with the covered with the amniotic membrane. We have seen just like it is a capsule has come out. So one opportunity to see such in utero baby like that outside.
Thank you, madam. Thank you for being with us and shared all your opinion. Thank you so much. Thank you so much.
Thank you, ma'am.
Thank you all the panelists. Thank you.
Thank you, madam.
Thank you, ma'am. Thank you.
Thank you,
Thank you, ma'am.
Radhika, for coordinating the session.
Thank you, ma'am. Thank you, Shanti Rani, ma'am. And thank you, Bhanumati, ma'am, and all the panel members. Uma, ma'am, Gayatri, ma'am, Ashika, Dr. Ashika. And now we move on to the question session. Chitrakala.
We really thank Dr. Ramani Devi and Dr. Sampath Kumari for Revati Janagram for this opportunity. It is a wonderful session. Thank you.
Yes. We are posting the second question, ma'am. Dating of twins is with larger of the second CRL, smaller of the second CRL, median of the two CRLs. Larger of the two CRL, smaller of the two CRL, median of the two CRL.
Time off, ma'am.
Okay. So the result will be announced after the vote of thanks. So as ma'am, Bhanumati ma'am said, I am also very thankful to the organizers, Dr. Ramani Devi ma'am, Sampath ma'am, Sharavana Kumar sir, and we are thankful to Dr. Milind Shah, who is a past Vice President FOGSI, and spared his time as a chief guest. The guest of honor, Dr. Bharati Rajshekhar ma'am, the President-elect Kasoga. And I thank Revati Janagram ma'am, who's a judge for the past for the Yuva session, and Dr. Karthika Prabhu. The first topic was dealt with by Dr. Ashika. Thank you, Dr. Ashika and Dr. Subhanya. It was a wonderful session. And thank you, chairpersons, Dr. Preeti Kumar ma'am and Dr. Malati Prasad ma'am, for chairing the session on imaging in multiple pregnancy. And the panel discussion was wonderful. Thank you, Shanti Rani ma'am and Bhanumati ma'am for moderating. And it was really a very practical session. Thank you, Dr. Gayatri, Dr. Vijayalakshmi ma'am, Dr. Uma ma'am, Dr. Rashmi Ajit and Dr. Anita ma'am. Thank you so much. And thank you, Chitrakala, for giving support to us. So thank you all, and we will wait for the results. Actually, we too had the first, in the house surgeon, the first case we saw was a triplet. We expected twins, ma'am. The third one, we could see the dark hair. Actually, it was fine. It's not. So we were actually scared. We were waiting for the placenta, but then in Tanjore Medical College, I did my MBBS there. So the third, again, there was a dark thing coming. We were all really frightened, actually. She already had 2 girls, and all these 3 were also girls.
Tragedy.
5 in government hospital. But now we had a triplet, 41-year-old IVF patient, and triplet, but they reduced it because of already she's hypertensive and GDM patient. So we thought best to reduce. One of
It shows how the field has advanced from our this experience and now what is happening.
But we delivered a triplet. Geeta Prasad ma'am delivered in Gosha triplet. The babe monitored all the 3, and she literally went on the labor table, and she herself did the internal podalic version. And she delivered one first by cephalic and second by internal thoracic. We all had that scan machine around and we did, but although it was not a very great machine, but she delivered all the three herself just in the labor ward itself. It was all great experience.
Something happens, yeah. Sometimes it happens like that. We also delivered a lot of triplets, either by cesarean or by labor natural also there. But it all depends.
Previously, fetal reduction was not there, ma'am. So
Yes,
we were
yes.
delivering
We have to
triplets
go.
very much.
We have no options and we have to go. Anyway, thank you, Uma, Chitra,
Thank you,
Anita,
ma'am. Thank you, ma'am.
and Ajit.
Thank you,
And
ma'am.
I think Sambat madam has left.
Yes, ma'am. We will we'll just wait for Chitrakala. Can you please post the results?
Kindly excuse me, I'm leaving. Thank you.
1 minute, ma'am.
Thank you, ma'am.
Thank you.
Thank you. Chitrakala? Chitrakala?
Ma'am, 1 minute, ma'am. I'm just compiling.
Okay, okay. We'll wait. We'll announce the prizes, answers of the prizes. What time is that? Just a minute, we'll check with it.
என்னாச்சு ராதிகா?
Hello? Ma'am, done, ma'am. Just, ma'am.
done. போடு.
Winners, ma'am.
Video open.
Winners are Dr. Gomati Venugopal from Chennai and Dr. Soundarya J. And she's also from Chennai. So congratulations to the winners. And thank you for participating. Thank all the delegates for participating in this TNFOG program, very informative program. Thank you, Sampath ma'am. And thank you all the speakers, Shanti Rani ma'am. And thank you for staying.
Sampath madam is there. Thank you, madam. Thank you, madam, for the opportunity.
Thank you.
Madam, thank you for the opportunity. Nalanda, madam.
நல்லா